I express my deep gratitude to all of you for giving your gracious consent to join us today to pay tribute to the most venerable and the colossal personage, Dr. K. Agarwal. Like the epitome of any literary work which has the prologue and the epilogue, the life of Dr. K. Agarwal has been the epitome of academics, education, passion to teach, and to disseminate the knowledge to the masses for their benefit. In fact, in his epilogue, that is, when he started his academic career, he actually declared his intent of disseminating the knowledge to the large number of masses for their benefit. And he did it relentlessly with a passionate penchant. And in the epilogue of his life, in his last show, when he appeared before the camera, looking little frail, with a faint smile on his face, but still the sonorous voice, he made his last concluding remarks: the show must go on. The way he said that, the show must go on, it appeared like a very honest and very sincere entreaty to all his friends and colleagues in the medical field to take on his mantle and to basically become the beacon, for the masses to disseminate the knowledge to more and more people in this country. Dr. K. Agarwal was a legion. And Dr. K. Agarwal basically has left for us the inspiring legacy. To pay tribute, to pay tribute and respect to such a colossal personage, I request all of you to please stand in silence for 1 minute. Thank you. I now invite Veena Agarwal, Nilesh Agarwal, Dr. Agarwal's son, Naina Agarwal, his daughter, Ankit Agarwal, his son in law, and please light the auspicious lamp as a sign of inauguration of this Lighthouse program.
ॐ गङ्गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः मङ्गलमूर्ति मोरया
ॐ गङ्गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः
Thank you. I'm sure that many of you who have had the occasion of being the co-speaker on many of his programs with Dr. K.K. Aggarwal, and many of you who have had various intimate
Success is not a gift. It is a reward of hard work, an incentive of passion. They say behind every success story
the memories of Dr. K.K. Aggarwal are crowding in our mind. But this is not a time to basically call upon each individual and request him to share his memories. And take a quick peek into the life book of Dr. K.K. Aggarwal by seeing his AV. Can we have the AV of Dr. K.K. Aggarwal?
Success is not a gift. It is a reward of hard work, an incentive of passion. They say behind every success story is a life of turmoil and hardship. A fight that withstood all odds. One such story is that of Dr. K.K. Aggarwal. From humble beginnings come the biggest heroes. Born as the seventh child on Janmashtami at 6 p.m., his parents promptly named him after Lord Krishna. Since a young age, Dr. Aggarwal was drawn to medicine, as for him, only being a doctor could help the people around him. As daily life posed the greatest challenges for a family of 11 living within the confines of a one-bedroom house, destiny had some plans.
ਹੌਜ ਕਾਜੀ ਥਾਣਾ ਪੌਂਦੂਮਲ ਨਿਹਾਲ ਚੰਦ ਦੀ ਬਿਲਡਿੰਗ ਦੇ ਵਿੱਚ ਉੱਪਰ रहते थे ऊपर बस मैं तो एक कमरा एक रसोई अपने बच्चों के ऊपर बहुत गर्व है पहली तो लाके दूर तक फर्स्ट आया पढ़ाने का उनको इतना शौक था ना बहुत ज्यादा भैनों भाइयों सारिया पढ़ाया है
His hard work was beginning to pay off. In the year 1974, he joined Deshbandhu College to pursue pre-medicals. Things were different now. A dream was starting to take shape, but the challenges were far from over. As life progressed, Dr. Aggarwal's dedication and commitment were his only support. Hectic entrance exams started taking a toll. Striking a balance became a challenge, and he missed several important opportunities. He joined the MGIMS Sevagram. After topping various MBBS and MD medicine exams, the year 1983 held great importance in the life of Dr. K.K. Aggarwal. It was the year when he joined Delhi's Moolchand Hospital as a junior resident under the mentorship of Dr. K.L. Chopra. There was no looking back. Within a span of a few months, he got 5 promotions and became a physician and heart specialist at the hospital. His urge to help society made him now pursue some other dreams. In 1986, with the help of Mr. S.L. Batra, he started the Heart Care Foundation of India, a healthcare NGO that today provides free medical help to more than 300 people every year and holds 3 Limca Book of World Records for hands-only CPR training. His time to give back to society had finally arrived. The next decade saw life changing rather rapidly. Dr. Aggarwal's stature grew many-fold within India's medical circles as he pioneered in bringing the latest technology to the evolving world of Indian medicine. His rise was complemented by the growth of the Heart Care Foundation of India. His NGO was now reaching out to many more underprivileged people who urgently needed medical assistance.
I have known Dr. Aggarwal for almost 40 years. He is, of course, a very good doctor. And my son, of course, as a human being also, he is very good and very genuine person. And very few people are like that. Professionally also, they are good. And otherwise also, he is very good. God bless him.
The fruits of this hard work were now beginning to ripen. National awards such as the Dr. B.C. Roy and the National Science and Communications Award poured in for Dr. Aggarwal. The most prestigious of all awards, though, came in 2010 when he was selected and awarded for the Padam Shri by the Honorable President of India for exemplary contribution in the field of medicine.
He brought me out from the jaws of death. He gave me certain tips, and by virtue of that, I'm leading a very healthy life for the last 22 years plus. He doesn't cure people, he puts them on path where you should remain fit and healthy.
In contribution to modern medicine, Dr. KK has continued to serve on the councils of various medical societies and associations in the country. He even went on to become the national president of the Indian Medical Association, with a singular aim to make India a power center in the world of medicine.
चौथे दिन क्या हुआ था आपको तकलीफ में?
सर मेरे को तो एक हफ्ता तक पता ही नहीं चला था कि मेरे को कुछ है। फीवर आया था 1 तारीख को और मैंने टेस्ट कराया था 14 तारीख को, जब मेरा थोड़ा सा बीपी बढ़ा हुआ लगा।
मैं आपका अपना डॉक्टर के अग्रवाल, हर रोज 1 घंटे हम कोरोना की, कोविड की बातें करते हैं। कभी डर की, कभी एंजाइटी की, कभी कोरोना से लड़ने की। घर में पीडियाट्रिशियन हो सकता है आपको ब्रूफेन या कॉम्बिफ्लैम की दवाई दे, लेकिन अपने डॉक्टर्स के बिना पूछे बच्चों को फीवर की दवाई ना दे। बल्ले बल्ले, अगर मेरे को कोरोना हो जाता है तो अपने आप को बोलो बल्ले बल्ले, एंड देन से आई एम स्ट्रॉन्गर देन द वायरस एंड आई एम गोइंग टू विन ओवर इट। स्प्रेड दिस मैसेज टू एवरीबॉडी। जब भी किसी से बात करो सबको बल्ले बल्ले। ग्रीटिंग फ्रॉम हार्ट केयर फाउंडेशन ऑफ इंडिया। मैं डॉक्टर के अग्रवाल। यस मिथुन जी, अभी चल अब है, बोलिए प्रतीक जी, विशाल जी, अभिषेक जी बोलिए, त्यागी जी, यस आशु जी बोलिए, ये सुमित जी बोलिए, रितीश जैन जी। अपने कमरे में बैठो, मेरे वीडियोस देखो सुबह शाम।
नमस्कार डॉक्टर साहब, मैं आज आपको धन्यवाद देने आई हूँ और मुझे बहुत अच्छा लगता है। मुझे एक नई दिशा मिली है, मेरा डिप्रेशन दूर हो गया जब से मैं आपसे जुड़ी हूँ।
थैंक यू।
और आप ऐसे ही हमारे को मार्गदर्शन करते रहें और हमारा जीवन भी बुढ़ापा अच्छा कटेगा सर।
नमस्ते सर।
नमस्ते बेटे।
हाँ सर, मैं आपकी बहुत बड़ी वाली फैन हूँ सर। एवरी डे मैं आपका, जब भी मुझे टाइम मिलता है सर, आपका सारा शो देखती हूँ।
मेरे को लगा पंक्ति पे मेरा नाम लिखा हुआ होगा।
सर मैं आपको देख करके ना, मेरी बेटी 14 साल की है सर, उसको मैं बोल दी कि आपको जब देखी तो मैं अपनी बेटी को बोली, बेटा मुझे सर डॉक्टर के अग्रवाल के जैसा तुमको डॉक्टर बनना है। कैसे है नानू?
हाँ, नानू आपका, नानू अगर नानू बोला है तो डॉक्टर बनना पड़ेगा। नॉन स्टॉप 20 मिनट शो आपके साथ में ऑन कोविड-19। पगड़ी पहन रखी है, ऑब्वियसली किसी शादी के फंक्शन में हूँ। फंक्शन के बीच में सोचा बस 20 मिनट आपसे बात कर ली जाए।
बहुत डर लग रहा है सर।
कुछ नहीं करना, डरने का जरूरत नहीं है। मकान आया नया, ना मिठाई खिलाई ना कुछ।
सर ये तो मेरा मतलब खुशकिस्मत हो जाएगी आपको, अगर एक भी मिठाई आप तो खाएंगे नहीं। फिर भी
अभी गुड ला के रखो।
नमस्ते सर।
यस बेटे बोलो।
अब कैसे आपको वैक्सीन के बाद कैसा लगा?
मेरा तो सीआरपी भी नहीं बढ़ा।
थ्रू आउट वर्ल्ड इज प्रेइंग एंड ब्लेसिंग यू ऑलवेज सर।
थैंक यू सो मच सर। ठीक है,
आई लव यू द बेस्ट।
थैंक यू बेटे।
मैं आपसे मिलना चाहता हूँ, मैं कब आऊँ आपके घर पे प्लीज?
जब मर्जी आ जाओ, जब तक जिंदा हूँ ये चलेंगे।
डॉक्टर आपसे
नहीं
इसी-
सर, आप
मैं आपसे रोज
हमेशा
इसलिए ही बात करता हूँ क्योंकि आप पूरी इंडिया को ठीक करते हो।
Even I am suffering from COVID. I am having COVID pneumonia, which is progressive. But even then, remember Raj Kapoor's word: the show must go on. Picture abhi baki hai.
सभी के हार्ट की दिल जान से केयर करें के, मोहब्बत से लगन से काम सब फेयर करें के। मदद मांगे कोई अनजान बंदा भी कभी उनसे, अगर कर पाएंगे तो देन एंड देयर करेंगे।
So much one can say of the life of Dr. K.K. Aggarwal, about his passion, about his contribution, about his commitment, about the care that he always demonstrated for his patients, that when one stops talking about him, one only realizes that there is so much left being unsaid. If there is anyone who could basically recall the choicest and the most intimate memories of Dr. K.K. Agarwal, I think there could be none than the family members of Dr. K.K. Agarwal. I sincerely request Neena Agarwal, Naina Agarwal, Veena Agarwal, sorry for this, Veena Agarwal, Naina, Nilesh, and Amit to please come to the dais and share with us, some of the choicest of the memories that you basically retained in your mind, which impacted your life, which basically impacted the vision of your life, which basically impacted so much that you rediscovered the purpose of your life. I mean, he was an epitome by himself. So I please sincerely request Veena Agarwal, Naina, Nilesh, Amit, to please come on the dais and share some of your choicest memories with all of us. And if I may say so, some of your most intimate and the most familial memories, which basically are unknown to the world outside. Veena Agarwal, please.
Namaskar to all of you. I'm Dr. Veena Aggarwal, Trustee Heartcare Foundation of India, and MD MedTalks, an online platform for doctors. At the outset, I would like to thank Mr. Bakshi and his entire team in Eris and Mr. Joshi for inviting us and having this conference, Lighthouse. What an appropriate name for Dr. KK. He indeed was a lighthouse, and he's lit up our lives and showed us a path that we are all striving to follow. We got married in 1985, and he started the Heartcare Foundation in 1986. So very early in life, after I met him, I could see his zeal for patient care, for issues that were hurting the doctors, and to do social service. I'm going to have to read because otherwise I'm going to get too emotional. Excuse me if I do break down. What do you call a man who served the people literally till his last breath, whose name was Krishan, who was born on Janmashtami, who lived life as a Virat Swarup of his namesake, Lord Krishna, who has millions crying and mourning his death, whose life embodied the mind, body, and soul of the common man, who called himself the collective consciousness of doctors and who did so much good for anyone and everyone selflessly and has inspired millions to carry on his legacy. A spiritual giant, a man like no other. Ever since the pandemic struck our country, he had been holding online OPDs over Zoom every day without fail, in which anybody could join and seek advice. He had stopped charging his patients much before the pandemic started, and his only interest was to treat more and more people without distinction of big or small, rich or poor. He had turned into a medical saint who firmly believed in the dictum, Bahujan Sukhai, Bahujan Hitai, for the happiness of the masses and the benefit of the masses. He was the most giving and ethical doctor I've ever known. He was an elevated spiritual soul with no interest in money or material things. He is the finest example of what the Bhagavad Gita preaches, to be detached to worldly things, including family, and to do his own karma without lust for benefits and rewards. We sometimes misunderstood him for being antisocial or boring or not looking after the family, but he was a truly elevated and exalted higher spirit, such that cannot be found in anywhere in today's world. In today's Kalyug, he was the true Krishna. This poem written by my cousin says it all. I'd like to share it with you. A one man army fighting invisible foes, relentlessly, tirelessly, forever on his toes. Every minute of his life spent teaching and working, sitting quietly at parties, smiling and smirking. He would be treating critical patients while planning a mela. There was no end to how much this man could do akela. An encyclopedia on every topic on earth. It feels like a joke when I compare my own worth. The pandemic set him off into a turbo mode, too soon for him to visit his heavenly abode. A monk, a guru, a man of science, and a man of dharma, steadfast in his resolve, doing his karma. For a man of KK stature, Karam Yogi, a Brahm Gyani, the man with a stethoscope, so many euphemisms to describe it. This conference is a very fitting tribute to him, and again a thank you for Eris Pharmaceuticals to do this in his name. It is our endeavor to honor his legacy of all the issues he believed in and taught for during his lifetime: the eroding doctor patient relationship, saving the environment, violence against doctors, and most importantly, the dharma and purpose of our lives, especially as doctors. People like Dr. KK do not go anywhere. He is with us, watching us, guiding us in everything we do, smiling and sending his love and blessings to each of us. Today, on the eve of his birthday and Teachers' Day, I want to take this opportunity to thank all our doctor fraternity who has not only served people selflessly through this horrific time and continue to do so, but many of these precious lives that have been lost while doing their duty. Dr. KK has been the biggest loss to me personally, but all of you who followed his advice, I want to take this opportunity to once again thank the millions of supporters who revered him and loved him for all the work that he has done. The outpouring of love and grief on his passing on has shown us what a true and selfless man he was. Dr. KK said his now famous last words, the show must go on. And he also communicated to us that his life has to be celebrated. He indeed lived one that we would feel proud to celebrate. He left behind a message for the entire medical community to be united and work for the benefit and keep the patient first. So let us all try and rise above the irreparable loss and celebrate the hero that he was, an unmatched spirit and soul. Thank you.
Hi, I'm Naina. I'm Dr. KK's daughter. Thank you so much for organizing this. This is definitely a great kickoff to his birthday weekend and to Teachers' Day. He definitely, he told us till his last days that please celebrate my life. And we really thank Eris for helping us celebrate his life truly. He knew, I mean, he did everything. I kept asking him, why do you work 12 hours a day, 14 hours a day, 18 hours a day even? And he used to say, you have to live life as if there is no tomorrow. You have to make the most of the time that you have, and you have to do whatever. You can't regret not having tomorrow, and that's exactly what he did. Last year on his birthday, we did a Zoom call with his family, and that's when he told everyone that I've achieved everything I wanted to achieve in my life. From now onwards, everything I do is a bonus. So, I mean, at the age of 62, for someone to say that I've achieved everything I wanted to achieve, now you must just celebrate my life. And from now onwards, I will do everything that I can, but I've lived my life to the fullest. If you ask me, I can't say that about my life. I can ask the entire room full of people here. I'm sure everyone will not have the same answer. So that's the biggest lesson we've learned from him. That one, keep helping people, keep serving the society, and do everything that you want to do and make the most of life. That's the message that I took away from his life and that I leave with everyone here.
Thank you. I think my mom and sister have summed up everything that I wanted to say. And I think it's the same with Ankit as well. Sorry? I think it's the same, pretty much the same answer.
Yeah, I think he's left us a big job to do, and we are working
We are
with
just,
the foundation.
we're working, we have kept all the shows alive, and we're still running all our patient awareness programs and all our doctor education programs. So, and we will continue to do so. And thank you so much for helping us organize this, and thank you everyone for attending. And I'll invite Mr. Joshi to come and announce the scientific agenda now. Thank you.
Thank you.
We in Aries actually sincerely thank Dr. Aggarwal's family because they chose us and they conferred upon us the privilege of organizing and supporting this program. And this symposium could not have occurred at a more opportune time than the coincidence of 5th September being the birthday of Dr. K.K. Aggarwal, that is tomorrow. And more importantly, it's a curious coincidence that 5th September also happens to be the Teachers' Day. I mean, this is really flabbergasting that Dr. K.K. Aggarwal actually chose 5th September to be born and to be a great teacher. And after his birth, his intention, was very clear that there was a purpose of being born on 5th September because he always wanted to be a great teacher. During the fag end of his life, Dr. K.K. Aggarwal conducted series of web-based programs and shows on COVID, on the prevention of COVID, management of COVID, the behavioral changes required during COVID time. He also conducted series of programs on vaccines because there was so much enigma that particular time surrounding vaccines. There was so much apprehension. There was a lot of ambiguity about vaccines. So he conducted series of programs on vaccines to basically carry the knowledge to the large number of people. And as we saw that in his own right, he was a COVID warrior. He was a COVID warrior. And I know that all of you sitting here and all of those who are watching this show have been and are still are the COVID warriors. We pledge our gratitude to all of you. Because the kind of commitment, the kind of contribution, the kind of sacrifice that you have been making being a COVID warrior has no match. And if you ask us, anybody from Aries, to say what we feel about all of you, what are our emotions of all of you, I am afraid, once we begin, it will never come to an end. So much, we feel about you. But rather than say this in words, we have tried to capture this in a big salam, in a video that says everything about what Aries thinks, feels about you. Our genuine, honest emotions for all of you sitting here. Can we have the
सांसों की टूटती डोरी को विश्वास से बांधा तुमने, जो छोड़ चुके थे उम्मीदें हर हाथ को थामा तुमने। भारत के हर एक दिल ने तुम्हें दिया ईश्वर का मकाम, है जीवन के वीरों तुम्हें एरिस का सलाम। एरिस का सलाम। ना रुके कभी भी तुम थक कर, सब भूख प्यास भी बिसराई हो, ना दिन देखा रात गिनी, ना बने हर मरीज की परछाई। तुमने ही दिए कई चेहरों को मुस्कुराहट के पैगाम, है जीवन के वीरों तुम्हें एरिस का सलाम। भारत माँ के योद्धा हो तुमसे ही कल और आज है, स्वार्थ बिना तुम सेवा करते, हम सबको तुम पर नाज है, हम सबको तुम पर नाज है। भारत के हर एक दिल ने तुम्हें दिया ईश्वर का मकाम, है जीवन के वीरों तुम्हें एरिस का सलाम। है जीवन के वीरों, भारत के हीरो, एरिस का सलाम।
we now start with our the scientific program, the first panel discussion. The first panel discussion is titled Impact of COVID in Clinical Practice. Are we now prepared for the next wave? For this panel discussion, we have the galaxy of super specialists and the confluence of such eminent and distinguished doctors is basically a very rare occasion for us. We are very proud to have all of you with us, and it is a very rare privilege to be in the midst of all of you. This particular panel discussion is going to be moderated by Dr. Mukesh Mehra, is MD DM, Consultant Department of Medicine, Max Super Specialty Tertiary Care Hospital, Delhi. You will have to excuse me for compressing the CV of all the faculties, because your contribution has been so exhaustive and intensive in your respective domain that if I were to basically go through the entire CV, I will run out of my breath. And I basically want to continue this particular session until the last moment. So I hope you will excuse me for this. Dr. Mukesh Mehra is MD FRCP Glasgow, FRCP Edinburgh. He's also a postgraduate in diabetes from the Cardiff University, UK. He has delivered more than 200 national and international lectures and web deliberations, and he has many national and international publications and associations as investigators in clinical studies. May I invite Dr. Mukesh Mehra to the dais? The next faculty member is Dr. Alok Aggarwal. He's a senior consultant at Gangaram Hospital, Delhi. He's an active participant in teaching programs of DNB students. He's an expert in microsurgery of ear and in functional endoscopy in sinus surgery. He was a president of Delhi AOI during 2017-2018. May I invite Dr. Alok Aggarwal to please join us on the dais? You are already here. Thank you. Our next faculty is Dr. Govind Makharia, who is a MD-DM. He's a professor gastroenterology and human nutrition at AIIMS. He is a medical researcher with a total of 299 publications, including the book chapters. It's a humongous work that Dr. Makharia has turned out. He is associated with the World Gastroenterology Organization for global guidelines on diet and gut. His editorial experience as advisory board, clinical and translational gastroenterology. He published approximately 300 publications, and he is having reviewership of almost 30 top journals, which are peer-reviewed journals like Lancet, like BMI, American Journal of Gastroenterology. And he received the Best Paper Award not once, 10 times. And moreover, and this is something very singular contribution of Dr. Makharia, he also applied for 9 patents, and all the patents have been granted. Our next faculty is Dr. Rajesh Chawla. Dr. Rajesh Chawla is MD, FCCM USA, FCCP USA. He is a senior consultant respiratory and critical medicine, and he has also an expertise in sleep medicine. He is attached to Indraprastha Apollo Hospital, New Delhi. He has a European diploma in intensive care. He is a past president, Indian Society of Critical Care. He is a past president, National College of Chest Physicians, and past chancellor, Indian College of Critical Care Medicine. May we have the pleasure of Dr. Rajesh Chawla to please join us here. Thank you, sir. Our next stellar member of this panel is Dr. Rajesh Rajput, MD-DM, Senior Professor and Head Department of Endocrinology, PGIMS, Rohtak. He has to his credit 150 publications in various international and national journals, and he has written various chapters in the textbooks. He also was awarded by Economic Times in June 2020 as the most inspiring diabetologist, endocrinologist. He also basically is a gold medalist by AR SET gold medal for the best research paper in ASICON in 2007, and silver medal for Best Poster Presentation in ASICON in 2010. He is the president of Indian Thyroid Society. May I invite Dr. Rajesh Rajput to be part of this panel, sir? Our next panelist is Dr. Pankaj Vats. He's a well-rounded personality. He's MD in AIMS, Delhi, and LLB. He's a medico-legal expert. Dr. Pankaj Vats is a postgraduate in forensic medicine from Department of Forensic Medicine and Toxicology, AIMS, Delhi. He's also a law graduate from MD University, Rohtak, and is having very vast experience of 34 long years in medical and health sector in government as well as private health sector. He has worked on almost all the positions in various health institutions run by the government of Haryana for 26 years. May I invite Dr. Pankaj Vats? Thank you, sir. And now I hand over the session to Dr. Mukesh Mehra. Thank you, sir.
Thank you, Mr. Joshi. I think first I will like to actually share my experience actually. So my journey in medicine when I moved to Delhi started in 1987 and or the first week of January 88. And the first man I met was Colonel Chopra, and he introduced me to Dr. K.K. Aggarwal. It was January of 1988. It was the first time, just after finishing my MD, I met the man with bubbling knowledge and the very overconfident man and never tiring guy. So my first interaction, the clinical, was with Dr. K.K. Aggarwal. He interviewed me twice in last so many years. They're all available on the YouTube and different platform also. And I'll share one experience actually. There's the first night, it was my night duty actually. So it was at 3 a.m. he called me, Mukesh, you have to come with me for a patient. So we got a call from Railway Hospital for a patient who required pacemaker. So at 3 a.m. he was with me. He finished round at around 11:30 in the night and then came at 3. Whole night he was there. He stabilized that old elderly lady, the Kashmiri lady, I still remember. And then moved next day, he gone his home and came back right at 9 for his OPD and echocardiography. That's the only place which was doing color Doppler echo, and I was with the NC and the program and all that. I was associated in organizing one conference also, but I left out 3-4 months later. So he was as a lovely man. He was a guide. He interacted with me many times. So I had a very small incident also. Remember, Ms. Aggarwal would know that in January or sometime that time you had some fire in your home and you lost some, I think, precious things. But he did not miss his OPD. He came for his work and all. I was so impressed with that man. So this is just my experience with him. So leaving aside, and we missed him. He was not only he actually made our presence in every house in the country. So when in the COVID time, there were 3 types of opinion. One is an international opinion coming from expert. One is WHO guidelines, and third, after All India Institute, it is Dr. K.K. Aggarwal's opinion, which has been actually we had to face every time, whether it's an indoor patient or it is an OPD patient. So his influence was so extensive. So now we will move on to first topic actually, the impact of COVID in clinical practice. Are we now prepared for the next wave? So so we'll start with how our personal life was impacted during COVID. As far as my own opinion goes, presently the impact in daily life is extensive and has far-reaching consequences, especially we healthcare people, because challenges in the diagnosis, quarantine, treatment of suspected or confirmed cases, high burden of the fluctuation in the existing medical system which we have seen in the recent times, and overload on doctors and other medical professionals, and overloading of medical shop, requirement of high protection, and we affecting our economics also, our social life also, closure of places of all kinds of, whether entertainment or disrupting all celebration, religious festivities and all. So, so my first question, I start with uh, Dr. Alok. We know the COVID-19 did not spare anybody and it impacted everybody's life. I'm sure it must have impacted your too. How did your personal life change after the advent of the COVID-19? So what is your actually personal experience regarding effect, which may be professional also, it could be social also, economic also. So how do you take and what is your expertise on that?
To speak uh, very truly, it started with Gali, right?
Yeah.
Gali to you know to whom. Then desperation. It was desperation, and we abused what has happened, what have I happened. Then emptiness, khaliness, and then came Modi ji and Thali and Tali.
Tali and Thali.
And that gave a boost to everybody. Not only the normal population, but we too doctors. We realized that yes, we are important and we have to do something for our society, not to just sit idly in our house and do the normal things. And we started then giving the lectures on the phones and the social media and educating the people, social distancing and everything. So from desperation, we moved towards this thing. This was in our personal life.
So it was a huge desperation for all of us. Actually, we all faced that challenge. It was a high burden of patient also and overloading of all kinds, and because of patients' high expectations also, our family expectations also, and we had a tough time. Or I think I think we have got slight relief. I think till the time if we escape third wave, I think it is good for all us professionals. Uh, uh, Dr. Govind, I'd like to ask you about did this COVID-19 cause you to discover some new patients in your life which hitherto remained latent and which you discovered during this time when you have been isolated from your active clinical practice and you have been forced to confine at home? Did you discover some new patients or just try to revive your old habits and old hobbies and all that?
Thank you so much. And my gratitude to Dr. Aggarwal that he left a big message for all of us
Yeah.
to follow. So taking your question that how COVID, certainly COVID was a difficult time, but it also brought a lot of opportunity. And one of the most important opportunity brought the power of, say, online teaching. So I'm a teacher. I teach at AIMS, New Delhi. So I've always wondered that how do we engage all the trainees, say in my field like gastroenterology, because in our society, like inside the gastroenterology, we do a program called YCP, a Young Clinician Program, where we call all the trainees for 3 days and discuss important issues in gastroenterology. But I thought that how do you maintain this, how to connect all through? And this COVID brought this opportunity to do online teaching. And that was, I think, is a big passion, which I want to do it, but now we can do it because of this opportunity of Zoom and other platforms. Second thing was that we did multiple master classes in gastroenterology, inviting all the gastroenterologists and trainees and a series of multiple classes. Now we're also doing second phase of that. There's a masterclass phase 2, where we're talking clinical case discussion with all the trainees. So I think the COVID brought a lot of good opportunity to us and saw the power of the online discussions, what Mr. Dr. Aggarwal had been doing for his patients during COVID times. So this is a wonderful thing to happen to us.
Yeah, that's wonderful. Actually, we all, being clinicians, actually, we enjoyed that part, actually, that webinars, interactive sessions, telemedicines, and all that. Rajesh, which was a new patient you discovered during this epidemic? Actually, you have been a very busy. I know you've been not only busy, you were the super busy man and had a lot of pressures. Also, VIPs also treating all those patients who are being shifted. Even I happened to interact for a few VVIP patients. Extremely busy. Although still you had some time in the initial part when even the admissions were restricted, you were not supposed to even move out initial day. So did you also discovered some new passion or just revived your old hobbies and all?
Thank you, Mukesh. Not really. Actually, I had practically all through the pandemic no time. Used to start at 7 and finish at 11 because the critically ill patients, I was the first one to go in, the first critically ill patient who was admitted in Apollo in 26th March. And after that, setting up new ICUs because it was much more problematic in the second surge. The first, I still had time because the number of patients was not that much. So, but I did not discover. We were just, because you see, how to treat these patients was a problematic for all of us. Steroids, they were effective, came little later. And how to save them, because we lost a lot of patients during that time. In second surge, although the total number of patients we lost was much more, but we could save many patients out of the ventilator, which we were not able to do in the first episode.
It was a learning stage for us. We learned during this time.
Yeah, and our time was most of the time used to pass in teaching the students who were taking care of these multiple ICUs, and then seeing the OPD patients. Because Apollo 24/7 there was a online, so I had to see patients also. So it used to be 10 o'clock. So I could not pursue any passion, but I enjoyed working during pandemic and taking care of these patients.
So this new passion or even the more involvement with patient care, I think that is you always been a very intensive clinician, always busy with the critical care and also heading many associations also. You keep organizing also, and I recently also saw you are again busy with the same old habit of some international conference you are going to organize or some national, very recent with the chest physicians also. And there's a critical care this thing, the forums
Not
also.
during this period, but I have been doing earlier.
And just a common question: how did your family respond to these challenges affecting during COVID-19? How was the response of the family?
It is always advantageous when your wife is a doctor because she can understand much better. She was very supportive all through, and the family, without family support, I think none of us can work. And there was a good family support and everything because during this period there was a lot of uncertainty in minds of everyone, whether you were busy or you were free, because a lot of people had surgeons, they had a lot of time, but in the second surge they were also involved in the patient care.
Yes, even
because
we were
you
all
required,
directly exposed to the patient. We are the highest patient with the highest risk. That's why
and-
the family was
and,
apprehensive all the time.
many
Our
of the
welfare also.
clinicians getting affected by the COVID-19, and there was a scare. But then, what I realized all through, and still I feel the COVID appropriate behavior we should continue for a little more while. I mean, the people have stopped in the city of Delhi, and the mask and the hand wash and little distance. We should continue
Very,
for,
very
I think,
important.
till November. Probably we might be through with this.
Dr. Achud would like to mention regarding your did you discover any new passion or just
Well,
happen to?
yeah, thank you very much. First of all of us are discussing that when they met first Dr. K.K. Aggarwal. Actually, I does not remember when I first met him, but I remember when I last met him. Before COVID pandemic started, it is actually CSI, which was organized in Delhi, where I was invited to deliver a lecture, and there I met with Nilesh. I do not know whether Nilesh is remembering or not, along with Nilesh in exhibition hall. So that was my last meeting with Dr. KK, and after that, obviously, all of us have gone into COVID pandemic. Coming back to what you have asked, actually. Now, honestly speaking, if you say hobby-wise, yes, I have developed a very interesting hobby. I have developed a hobby to de-learn what actually I used to believe I know. I am an endocrinologist by profession. So I know there is a lot of diabetic problems which are coming during pandemic. So we have taken care of that in institute. We have taught our students, not only students, our general practitioner colleagues across the country to take care of diabetes properly. But at the same time, in our fraternity,
Some of us started thinking that we know each and everything. But with COVID, I have learned something that you have to de-learn and then you can learn. And that is true. In COVID, when the first wave started, we started believing that this is a disease where ventilators are a must. As time goes on, our learning changed. Steroid become the therapy of choice. And as learning goes on, we came to know that there is a disseminated coagulation throughout the system. So probably ventilators might not be that much helpful as we have initially believed, though they are still useful, but might not be that. So there is a lot of de-learning and learning which we have done. And apart from my endocrinologist hobby, which I still pursue with passion, what I have learned that I have generated a new interest in infectious disease. Because as a physician, whatever is your super specialty,
So
you
all
are
medicals-
bound to know about basics because society expect, as what Dr. KK is doing through his videos, the society expects from you the answers, especially in problems like pandemics. So developed a new hobby. Apart from that, as Dr. Chawla has said, honestly speaking, even in institutes, we hardly have a time to even spend some good quality time with the family or to develop a new hobby. And we have developed a new thing in institute. I do not know how many institutes have done that or not. Especially in first wave, we have developed a multidisciplinary team. And that multidisciplinary team used to take a daily round of 2 hours, and our residents, senior residents, junior consultants who are inside the ICU, they used to give us rounds for all those critically sick COVID patients, and all those patients are discussed. And I tell you, that has made a impact. That
Thanks,
has
Dr.
made a
Rajkumar.
difference because
So
of our
in nutshell, actually, we all professional, whether it is new hobby or it's old
Yes.
hobby, it is patient related and related to
Obviously.
profession also. It is nothing beyond
Nothing.
your profession.
So this is the thing which I have learned during the COVID. Thank you.
So now we'll move on to another aspect. Actually, how did COVID change our practice? Actually, so we know there is an increasing gap between the doctors who have traditionally been trained to do and realities of modern clinical practice. There are recent study that the moral among doctors is generally declining during this time. And in a survey of UK, we show that almost 54% of physicians reported their moral as a low or very low. And there is also a study, there's approximately, when you talk about the burnout, it is prevalent up to the tune of almost 70 to 80% in professionals. And there is a crisis in staff retention in some countries with a gap of up to 48% doctor considering leaving the profession. So COVID-19 exacerbated these tensions between the medical professionals, physicians' well-being also. So it has been a big problem. So because of the under-resourced medical system, they tested doctors and healthcare workers to the limit of their professional competence and taken a considerable toll on the family and our own well-being. So do you think that these changes are going to be new normal now, Dr. Alok? So these changes which we have seen, we are continuously under pressure, we are apprehensive, we have a feeling of being low for most of the time and feeling burned out. So how do you feel actually? Now this is the time when this, with the mucormycosis and other ENT related subsequent problems also keep you at always on move and always apprehensive about the patients who've been referred. Rather, this is the first time we saw so many complications, newer type of complication. We lost many patients also. So you feel this is the new normal now, or we're going to have some kind of reprieve in your near future?
So, as we Indians have very short memory, and we humans also have very short memory, I think the things will come back to the normal. It will be not new normal. Everything is reverting back. People are still, the third wave is being expected, but the people are not wearing the mask. Sanitization, yes, people are doing, but new normal, I don't think it will come in our society. But as a doctor, yes, we do, we not to wear the mask in our OPDs unless until we are operating or doing something. But now in our OPDs, we will wear the mask, we'll do the sanitization, we will use the gloves. Previously, we were not doing. So some new normals will definitely develop. But I am afraid that the society will change much. I don't think so.
Dr. Makari, did you and any time sense that the changes in your practice which cause little discomfort or to your patients also, besides family and yourself? So it is really make a difference to your patients also. Your approach change, their expectation change, the society as such, our approach is changed. Do you feel that there's some kind of, I think, some kind of inconvenience which has happened into our relations with patients and our approach?
Absolutely. It has changed markedly and for bad, not for good. Because the medicine is a practice of science and arts. Science we still practice, but arts has gone. The doctor-patient relationship is extremely important.
Yes.
You put your hand on patient's shoulder, patient get reassured. We don't do it now because of other issues, but that's so important. And what William Osler said, that practice of medicine is only good if you practice like a physician. As a doctor, we can do, as a professional, we are professional, and for which we are paid for. But the empathy you show to your patients and their family, which cannot be paid for. And for that, they fold their hand in front of us. For that, they say, you are God. But that part is going. That must not happen to this profession.
Yeah,
This must not happen to this profession, because science is one part, but again, art of healing, the art of talking to patients is extremely important.
Very, very.
So second thing is that there's a barrier now. There's a patient and the doctor, and there's a glass in between. To protect us, we have put glasses in front of all our outpatients.
Yeah, definitely.
So that glass puts a barrier among the families and patients.
That proximity
That brings
is gone. Even
a gap between patient and doctor. That's not also fair. It must not last long.
even the physical
Till
touch is
as
gone.
we get back to our normal in maybe next year, 2022 or so, but we must remove these glasses between patients and doctors.
Even that holy touch of a doctor is gone.
Absolutely. And third one, that we started giving advice on phone, and this what really happened, that unless you see a patient and examine, you miss many findings. And this really happens because any disease will have multiple symptoms. A symptom is of a benign disease, a symptom of a malignant or serious disease can be found only on good examination. In COVID times, we have probably stopped good clinical examination. So this goes too long now, 2 years now, 1.5 years. It must not come into our practice or habit that we don't examine patient and take a call and or see in the OPD and make a diagnosis, or send for a CT scan or ultrasound without examining patient. So these are some of the things which are bringing barrier between patient and doctor. Therefore, our patient must not be satisfied. It's easy for us to practice because you see on teleconsultation, you see without examining patient. So patient is also happy that they don't have to come to your clinic. They're also happy. Phone kar liya, baat kar liya, and then you get a prescription on your WhatsApp. But we might miss a number of issues by this practice.
Dr. Rajput, did you ever thought this change might affect the satisfaction level of your patients?
Actually, if you talk to me, I totally agree with. We live in a country where social norms are totally different from our Western countries. People feel more satisfied when you examine them physically rather than just talking to them on the Zoom platform or whatever platform, digital platform. So there is a definite difference in West and East. Not only that, whatever we may say, the most difficult thing in the history of mankind is to change human behavior. Now, what is COVID? COVID appropriate behavior is changing human behavior. In the society where we are living, the behavior which I have learned over last more than 50 years of my life, how I can change overnight. So these are the things which are not going to be changed immediately. So we have to find a solution, alternate ways. And digital for a time being is an alternate way. Now, as far as glass you are talking of, to tell you, we have never put a glass. Throughout the 2 pandemics, I have never stopped my OPD in institutes. The government has not allowed us. We have run all the OPDs, and there was never a glass.
But at the same time, we have maintained a distance, and physical examination actually has not been done properly. And it is not only patients, I tell you, because working in institute, you might have also experienced, we have taken examination. Our students, last 2 years, they are not doing physical examination of the patients. So their learning has suffered. It is not only patients. Learning of the new trainees have been different. Not only their learning is different, the method with which they are assessed in examination is again totally different. So this should not last long. Otherwise, we have to design different ways so that in long term this should sustain. Otherwise, this is going to have a great impact. We are producing doctors which have not done physical examination, which has not been examined in a way. Ideally, they should be
So
examined.
there are new ways of learning
Yes,
also and
and then
practicing
lastly, which I think our colleague is going to answer, there is a huge medical legal implication.
We'll discuss, we'll take that part
Recently, because the government and Supreme Court is now forcing that all COVID who have succumbed to COVID, they should be given compensation. So lot of medical legal issues are going to come. Now, so those things are also to be kept in mind. Initially, we are liberal. A lot of us are prescribing so many things without understanding the medical legal aspects. Now, those things are also going to come.
Dr. Chawla, what's your opinion on that?
No, I agree with him, whatever he said. You see, now with the new Supreme Court judgment, which I think came yesterday, you only
just
told
2 days
me
back.
that if your prescription is faulty, you could be prosecuted. I mean, this will prevent a lot of people getting an online consultation. They should have a middle path. You can't just penalize the doctors, the first, second decision on the doctors.
Yeah, as soon as the judiciary resumed, the first
You know,
decision
because,
came
you know,
against doctors.
It is convenient, like a person who's coming from Bihar for a small consultation, he can take a consultation online, but then of course there should be a check and balances, but not the doctor would be prosecuted unless it is a very big mistake.
So now we're moving on to other part, that is telemedicine. We know in order to avoid face-to-face contact without hampering healthcare provisions, the telemedicine, which is now a part of digital health system of various countries and need to be applied more effectively. That's very, very important. Except for acute cases, the chronic conditions, follow-up visit, they all can be managed using telemedicine. And the unnecessary hospital visits are reduced while ensuring triage and treatment of the serious ill. And the World WHO also consider telemedicine as a mode of healthcare delivery when the distance is a critical factor. So this is all new things. So in order to be effective, the health providers should have the necessary education also. There's sometimes licensing also, and sometimes professional capacity to deliver healthcare services through telemedicines also. So we will take the opinion of experts subsequently. First, we'll take, given these uncertainties about COVID-19, do you think the telemedicine, Rajesh, is going to be a future way of managing or chronic and follow?
Very convenient. You know, we in Apollo and otherwise, I think all of people in the bigger hospital, they get people from outside. And there are follow-ups where you hardly do anything, which you can do on the telemedicine, and they can come once in 3 months or 4 months. The visit could be reduced. So this could be very useful. And particularly in his branch, they could do a lot of consultation online. I mean, in diabetes and which thyroid, diabetes, because most of the time the reports, they are very important and they can be consulted. So there should be a middle path where what can be done and what cannot be done. That may be laid down, but it should be allowed. And
but we should all learn, actually, our patient also, how to use this telemedicine or tele consultation for that matter, because it's a lot of time consuming also, and we are basically, they have been not made aware how to approach. There's certain consultation, app-based consultation, but they don't they follow the advice, right? Complete history they are supposed to, all reports, past reports, and everything should be uploaded before they consult you.
No, but if it becomes a new norm, patient would also know that they have to upload and what they need to know. And the software will also, you know, online, people in this pandemic, they've really moved forward. And with time, I think this is a new normal, but in a limited manner, probably.
Yeah. Yes, sir.
Actually, if we see for first consultation, whether it's a chronic disorder, and obviously acute is out of question, first consultation has to be face-to-face. where a physical examination is a must. After the first consultation is over and you have put down your proper notes, I believe teleconsultation has a huge role, especially in chronic disorders, whether it is diabetes, whether it is thyroid, whether it is rheumatoid arthritis, because here again and again, same physical examination, there is no need. And very recently, Association of Physicians of India have actually brought down the guidelines, because from those guidelines for thyroid section, because I am president of Indian Thyroid Society, I am a author. So we have written all these things, that there can be various things like patient loading their entire reports, so that doctor can review the history, the reports, and then can even give appointment that I will be available 2 days, this time slot. But obviously these things will evolve over time. And I still believe if third wave will not come or will be a milder one, and soon because of vaccination, if we will be out of this COVID zone by next year, anytime middle of next year, then probably all of us will forget the digital platform. Remember it. Everything will be back to the normal.
So there is an urgent need for a system
Yeah,
level approach
absolutely.
to address the issues of the COVID-19, which has created to better protect and safeguard our medical workforce for the future. It's very, very important. So I think telemedicine is going to be so there are a lot of I think aspects which we are going to see face as a clinician. What is your opinion, sir, on telemedicine? How useful it has been for your practice and your patient care?
I think I completely agree with uh, that the first consultation must be face to face. The telemedicines have a lot of advantages, but it also has a lot of limitations. For primary care, telemedicine could be a good, acute care. But chronic care, as Sir said, that chronic care is a continuous care. Chronic disease care is continuous care. Certain diseases, diabetes, we know HbA1c, thyroid, TSH or T3 or T4, or free T3, T3, T4. They're fine. But for many diseases, you need to we need to see patients, you need to examine patients. Like, for example, you treat patients with cancer. You need to see patients. You cannot do teleconsultation for such kind of disorders. Certain disorders which could be good, we can treat from distance without seeing face to face, based on based on the lab reports or something, which are our objective. In diabetes, objective is to keep HbA1c to a certain level. But in mitosis, in cancers, there are different outcomes. So we need to be outcome-based consultation. So teleconsult could be good for certain disorders. And in fact, this is the boon. For example, we see patients with hypertension and say that I see today and see 3 months later. But that's not care of hypertension. You have to see that the BP remains under normal values all through. And for that, this could be teleconsult, could be, there could be different platforms that you type on your phone. My BP today is 120/80, tomorrow 160/90, the next day is 160, say 96. You know that this has to be cared for. If you leave this BP uncared for, then probably we are leaving.
So there has to be a balance between both
chronic
for the chronic and the regular follow-ups.
Likewise.
Dr. Pankaj will take your opinion in subsequently. Then you will speak. We'll all listen. So it's all hanging for you. Your opinion, Dr. Alok.
My opinion is different as far as the telemedicine is concerned in India. It is very effective in acute conditions like in COVID. No doctor was available on the line, in person, and everybody showed on telemedicine. But the flip side of it, one prescription was written for a particular patient, and that was followed by the number of the patients. Irrespective, the other person, the doctor has given what medicines to that particular patient, but that was being followed blindly, right? Over the counters, the medicines was being given, likewise the prednisolone or these steroids were misused like anything. So in India, where we have a population who doesn't think that it is mandatory to be examined by the doctor, every patient is a different patient, every disease in a different patient behaves differently, right? So many of us have this COVID disease, but unfortunately, some of them didn't survive, even doing anything.
So it should be a mix of both actually. You
Yes.
have to select your,
Yes,
depending
so-
on the, but the acute care cannot be given through telemedicine. Acute care is always mandatory, but chronic and the follow-up visits, you can
Follow-up
always,
visits can be given.
because you have to protect the medical fraternity also actually. You
Yes.
never know which patient is a carrier, which patient is going to, because it is just matter of rather fraction of second that you get exposed and all. So you have to take precautions also, and you have to take mix of everything,
Yes.
whether it's a physical
Yes,
or.
you cannot just give like medicine on the phone, or
So we-
and in fact, I in my opinion, the telemedicine is very difficult one. All right, you take much of the time in first seeing the reports of the patient, then listening to the patient, then answering, then giving the prescription, and after that taking the follow-up questions.
Yeah, thank you, Dr. Alo. So now we want to something positive actually. COVID-19, is there light at the end of the tunnel? So there are many speculation regarding COVID-19. For example, Dr. Swati Nathan of WHO recently predicted that COVID-19 is gradually taking the endemic form in India. And there is a speculation regarding the third wave of COVID-19 also. And there are variants of COVID-19 like Delta and Delta Plus, which are found to be more infectious, and patients are falling prey to these variants of 19. And it is also speculated that COVID-19 vaccine may have to be taken every year. And in this backdrop, do you think that there is going to be an end to this COVID-19 phenomenon ever? Or our lifestyle changed, like hand sanitization, mask, social distancing are going to stay forever? Is life ever going to be normal again? Dr. Chawla? So is there light at the end of the tunnel? How is the future?
I personally feel that probably we will not have a third wave that's strong. Even if it comes, it may be in spurts.
Yes.
And very soon it is going to take an endemic form.
So it is
And
very assuring
because you
when
see,
coming on the space
the most of the Delhi,
Yeah.
I mean, many of the people had disease, and
Yeah.
now the speed the vaccination is being done,
Very
this is going to stop. And probably the trend, the way it is, Kerala is having so many cases still only in that particular area.
It's
But
confined
you're
to
not
that
seeing in any other part of India now. And Delhi hardly seeing less than 50 patients. So probably unless there is a mutation, there is a big mutation which is different, which is also less likely because with time the virus also dies down. So probably we may have a just endemic form. That's what I feel.
So
I mean-
anything regarding herd immunity, how we are going to get this herd immunity? Through
Herd
this.
Herd
we have-
immunity is already zero
there.
surveys, more than 65% in
Oh.
Delhi.
Yes.
See, if you
And the
see,
average nation is about 50%.
absolutely, if you see
Yes.
zero surveillance data from entire country, almost more than 50% of the population has already suffered. Over and above, now more than 50% of the population has received the first dose of vaccination. So probably we have already reached the herd immunity.
Yeah, 65% population, one
and
vaccination.
COVID is going to stay with us
Yes.
throughout our life. Only thing is that it is going to be an endemic disease, and we have to learn to live with it. And
Because
I
we-
agree,
we
probably
already
third
have-
wave,
yeah.
third wave is going to come,
Yeah.
but severity might not be that much, which we have seen in the second wave. So it will come in spurts in some part of the countries, which has been spared in the second wave, where people are still not vaccinated. There it might come, or children's as, but still I believe, I put big question mark on this theory of children's in India. The reason is, in our country, if one person get affected in the family, the entire family has actually got an infection,
The whole
even if
family
they are
is
children's. So although we are saying our children are not vaccinated, but somehow they have got subclinical infections from their elderly. So I think I agree with him.
Dr. Raj, I'll require your comments on that also. So up to, because ACE receptor they develop at the age of 11 only. Up to the age of 11, the very limited ACE receptors are there. So the chances of getting through ACE receptors is very low. But between the age of 11, 18, which was the biggest apprehension, because 18 above, the vaccination schedule is quite intensively taken over. Almost one vaccine is given to almost 67, 68% of population. Almost 15 to 20% population in certain places, 35% person had two, I think, vaccination doses. So this 11 and 18 year was basically, you rightly said that if one person exposed during the second wave, the whole family was exposed, but it was not there. So in the first wave, actually, if you isolate, you could actually you could have confined it to 1 or 2 family members also. So regarding this group of 18, 11 and 18, which has been apprehension overall through the many agencies also and the many platforms also, what is your take on that?
You asking me?
Rajesh Chawla.
No, I mean, they have now going to start for less than 18 also.
Yeah.
And till 12, and by the year end for the small children also. So probably, and they are going to be very quick in giving. Now they are giving almost more than 1 crore vaccination every day. So probably we are going to have this disease and endemic like swine flu. Now we have to think whenever a person presents particularly in the hospital with a serious illness. Similarly, all our lives will have to think COVID also. It's not going to disappear. It will be endemic. Sporadic cases will keep on occurring all the time.
And probably we have to take a booster dose every year. Recently, just last week only, publication has come up from Oxford University where they have shown COVID vaccination, response of antibody after first dose, response after second dose, and response after third dose. So after third dose, the response is further enhanced. So probably in US, they have started booster. In UK, they are started with booster. In our country,
Israel has already
yes,
completed
in our country, probably it takes some time. But I think by the end of this year, the government is going to take a decision, especially for
definitely there is a hope at the end. I think there is
Yes,
a light
obviously.
at the end of the tunnel. I think now we move on to our concluding topic that is very, very important actually. Now Dr. Pankaj is, I think we will highlight all medical legal aspect of how COVID has affected the medical legal aspects. And when you know, in India, the first case COVID-19 was reported on 30th January 2020 by Ministry of Health, Family, where in Kerala. With the Thrissur district. On 11th March 2020, the WHO Director General also briefed the media as operating a statement of COVID-19 outbreak as a pandemic to worldwide. So in the recent literature data search, very few articles found which compromise the ethical and the medical legal aspect related to COVID-19 pandemic situation. Therefore, it is very, very important to evaluate and review the Indian medical legal aspect of COVID-19 disease, such as the Epidemic Disease Act of 1897, the amendment to Epidemic Disease Act 1998 also, and the Disaster Management Act of 2005 also, even the Biomedical Waste Management Act also, this telemedicine or teledentistry in the pandemic era also. So these challenges of COVID-19 are huge, but the basic principle of law can keep healthcare personnel out of these medical legal work. So we would like to, I think, hear from you. If you have any presentations, sir, you can give or we can.
Yes, I have a presentation. If some can quickly go through the presentation. And before the presentation, actually, I'll want to say something about the motivation which I got from Dr. K.K. Aggarwal. I did my MD from AIMS, then I went back to my state and I became yes. Presentation. Okay. From where? Just 1 minute. So, in 2006, I became the youngest civil surgeon in Haryana at the age of 46. So I was motivated by Dr. K.K. Aggarwal. I wanted to give back to my society. So I remember I was civil surgeon Faridabad at that time, and I came with my entire team of deputy civil surgeons to visit his health mela. Perfect health mela ke naam se health mela, he used to do it for 2, 3, 4 days, because usually the concept was 1 day's health camp. And you know what is the health camp? Somebody goes with some medicines, a set of medicine is there, a set of doctor is there. All the patients are treated by that doctor only and with those medicines only. So the concept of perfect health Mela was different. It was for longer duration. And from there, I got a clue. My whole team went there and visited the perfect health Mela going in Delhi. And then we followed a 5 days health Mela in Faridabad, 5 days health Mela. The Mela started at 6 o'clock with prayers, with yoga, and then sandhyas and other things and all that. And in 5 days, we treated 60,000 patients with all investigations free of cost, MRI, CT scan, like treatments. So I remember that he was really Lighthouse. We took prerna, unse prerna lene ke baad we conducted that health meal in Gurgaon. So I had remembrance of. During that time, I met him personally and took certain guidance also about that particular concept also. As far as this medical legal concept, medical legal issue is concerned, Dr. Rajput has very well pointed out. Then now the medical legal issues are at the top. If you do something good for anybody, you may not get anything in the return, but you do something wrong, then he is after you. So similarly, the medical legal issues, when it comes, who deals with medical legal issue? Police, they don't know ABCD about the health. Judiciary, they are very powerful, so they don't think that they should know each and everything and all that. Whatever you did during all this era will be evaluated by them according to law. Otherwise, see the Epidemic Act, Disease Act. After 123 years, they framed regulations. Usually when act comes, so after act, rules and regulations comes in say 1 year or 2 years and all that in the process. But they had 123 years. They took 123 years for the regulations because they need it. They're powerful. They made those rules and regulations according to their wishes, the way they want, and they don't want to do that. See now, medical legal aspects may, the total it has been masked, the medical field, because various acts, rules, regulations, orders, guidelines, instructions, they have been made applicable. Law made applicable on doctors, clinical establishment, on their working, including treatment being given to both COVID as non-COVID patients. You are not free to treat the patient the way you were doing in your specialty all the way. You are being guided each and every step. And if you use your brain or your clinical assessment, and that does not come in the parameters given by those guidelines and all that, you can be sued. Because with that particular instruction or that particular guidelines of the Government of India or Ministry of Health and Family Welfare, and whatever treatment you can give, that goes, the judge will see, the interpretation goes in the favor of that you have not done this thing. So they have masked each and everything. They have told us what investigation has to be got conducted. RT-PCR test, or this test you will get it done. Other tests you will not done. CT-PCR test you will do or you will not do it. So all these things has been taken over. Even immunization has been done. क्या आप इस age group में करेंगे, इसमें करेंगे, नहीं करेंगे, क्या करेंगे? Now so many limitations are there. It has affected doctors, paramedical staff, clinical establishments, even our professional ethics, treating procedures and diagnostic parameters. Nothing is free without medical legal aspect. See, even medical death certificate, the quality of information in this has become very crucial. Even the case is pending in the Supreme Court because you never bothered. You just write down what is the cause of death because you are suffering from this thing or he has got a heart attack or whatever like this. But now in this, whether he has died of corona or not, whether that has to be mentioned in the certificate or not, death certificate, that information has to be given or not. It is moreover like in earlier stages when we have to declare somebody a patient of cancer, So it was very board will sit and so many things will go. And then we used to say it like this. So now cause of death, whether it is due to corona or not, it is a very Hercule's job because the financial implications are there. That the government is giving compensations for dead people or for the kids whose parents have lost their life. So that's why it has become very crucial. Even PIL has been found. So when you write the cause of death, you have to be very, very careful. And if you say it's due to corona, then you have to justify it. Because as per government instructions, only the RT-PCR test is positive, then only you can say that he has died of the corona. If test is not positive, you can't. Even your CT chest and other things, and you treated the patient for that. For your board of doctors has treated the patients for that, but you cannot declare it. So now the PIL has been put to the court. In Supreme Court is pending. I think the decision is going to come about that. They will guide you. They will tell you how to write a report, how to write a death certificate. And we doctors usually don't bother about those particular things because we are clinical and we always try to help others, but this can lead you to trouble. For example, you have written that he has died of the corona. He is asking for the compensation. He went to the government is not giving. He will go to the court. Then you will be called again there as a witness. Then you have to justify in front of that particular court again. So all those things, those guidelines has to be treated. So even that has become very crucial. Even management of corpse pandemic has become a very vital issue. Because suppose if it's in a small nursing home or a clinic, if patient comes at the end, fake end, when he is very serious patient, and suppose he died there, and you know it clinically and from the history that is a patient of the corona. So now you are in dilemma whether to declare it or not. Because once you declare, then you have to follow all those protocols for the management of the corpse, which your nursing home or clinic is not having those particular facilities and all that. So everywhere the medical legal aspect has come. I was telling about this Epidemic Disease Act. It was 123-year-olds and the regulation has been formed. It is applicable on now. Indian Penal Code has become applicable on you. Disaster Management Act of 2005. There are so many government notifications. I was calculating, there were 480 notifications from January 17 till April 19. After that, I started I'm not counting the notification which has gone on that. How many of you know about these notifications? I don't think anybody of us has gone through any of the notification carefully about this. But every notification do have medical legal issues on our treatment, on our judgments, on our they can create litigation positions to us. See, act is different. Then they have the powers, they have the orders, they can by various state and by various local authorities. Even local authorities are passing so many orders and all that which you don't know. You don't know those orders passed by district magistrate or this sub-divisional magistrate doesn't come to you. So you're not aware of about those notifications and all that. But once the problem comes, that notification can create a problem for you. Then guidelines issued by WHO, medical boards, regulatory authorities. You're saying it is not a repetition actually. Everything is important. Like rules are different, regulations are different, instructions are different, government orders are different, instructions are different, guidelines are different. Everything goes on your impact. Now, after 123 years, Delhi, Haryana, almost every state has made these regulations to 2020. I don't believe hardly anybody have read this regulation, hardly. It has got a lot of implications on your career. You have to go through it. There was an act, PNDT Act, if you remember. In PNDT Act, several thousand doctors has been jailed. And act is very small. Even these epidemic regulations are very small, say 5, 6, 10 pages only. But nobody has read it. Even read it once, they cannot. go through those particular things and all that. So according to it, during COVID period, any patient comes to you, you must have a pro forma of self-declaration. Because if you don't have those particular information, if there is a proof that he came to you and after few days he went somewhere else, he is a corona positive case, and something happens, then things go back that he came to your place also, and you miss this thing, you have concealed the facts from the authorities. So this regulation has become very, very vital, very, very important. Now, very important thing is that you must have heard, kabhi suna hi nahi hoga, socha bhi nahi hoga, you must not have ever imagined. Then a sub-divisional magistrate or a deputy commissioner can acquire a corporate hospital. They can acquire not only the corporate hospital, the building, they can acquire the whole staff, the equipments, everything. And then they can give it to civil surgeon to follow it up. You must have heard about it. Even NCR in Gurgaon, 6 hospitals were taken over by a simple order. And you know what act was used in that? There is an act called as Haryana Requisitioning and Acquisition of Immovable Properties Rules 1973. 1973 में, as per this act, हमें याद हम पल्स पोलियो के प्रोग्राम में, during pulse polio program we needed lot of vehicles. So during that we used to go to deputy commissioner, and deputy commissioner can send a letter for requisition to the police that so many vehicles are required. और पुलिस वो vehicles लाकर हमें देती थी, गवर्नमेंट के जितने vehicles होते थे उन सबको एक्वायर कर लेते थे. लेकिन never heard that the whole hospital can be taken over with your staff, with your equipments. Such an order Delhi Epidemic Act में आप देख सकते हैं suspected COVID-19. अब now Delhi Epidemic जो COVID regulation जो act है उसमें what you have to do is, if a patient comes to you, you have to take history and declarations from him, contact history, and you have to declare. So time is less. I am quickly going through that particular things. Delhi epidemic के चीज हो गए, सारा हो गया. या part देख लीजिएगा, effect of medical fraternity. And now, what I want to say is that through this August office of Dr. K.K. Aggarwal, through this we can think that if doctors' medical fraternity is at stake, there should be certain guarantees should be given to us also, to doctors also. Like in these acts, in all these acts, there is a clause. By that clause, if any officer or any state government or any authority does any work in good faith, so no action can be taken against that officer or that authority or that government. So we must insist on the government that during the execution of this epidemic act or this disaster management period, whatever act is done by doctors or by big hospitals or nursing home owners, then that should also be treated in that particular category, and no suit should be launched against the government. So Section 4 in the Epidemic Act, then Section 73 in the Disaster Management Act, no suit of prosecution. That's why in Andhra Pradesh, 58 private hospitals were taken over by the government authorities during this particular power. Yeah, this is the order which a magistrate has passed. Simple one-page orders, half-page noting. 7 hospitals were taken over by the government. These were the hospitals: Metro Hospital, Narayana, Signature, V. Pratiksha, Columbia, and Park hospitals. Now, my recommendation is that during this epidemic and when these acts are there, the government should give professional indemnity insurance to all the medical and paramedical staff and the hospitals. Second, this protection, which I referred earlier in various sections, they should be doctors, paramedical staff, and hospital managers. They should also be included in that category, that anything done in good faith should not be there. No litigation, no suit or legal proceedings shall lie against any treating doctor, owner of clinical establishment for treatment given or action taken in good faith during these periods. They should be given relief from prosecution of alleged grievances of patient for non-compliance of provisions of Consumer Protection Act, National Medical Commission Act, Indian Penal Code, Clinical Establishment Act, even this Biomedical Waste Management Act. Rules, because they are also working in extraordinary and exceptional circumstances. So these are the recommendations which we can do it. Thank you. So nice of you. Any questions? I can.
Thanks, Dr. Rai. Dr. Pankaj, for enlightening, I think, the most difficult aspects of our professional practice and all. Thanks, actually, all panel members for their wonderful, I think, opinion on the subject. I'll request now Mr. Joshi to please take over and move this further.
Since we are running out of time, and to be able to conclude our session on time, with your permission, I suggest that we merge the remaining two sessions, and there are three panelists for the case presentations. So I would basically request Dr. Rajesh Chawla to be on the dais, Dr. Suryakant, yeah, and Dr. Yash Zaveri. With your permission, I would request Dr. Yash Zaveri to make one case presentation. And I would like to first, introduce Dr. Suryakant, who is a professor, head Department of Respiratory Medicine, King George Medical University, Lucknow. Yeah. And he's a member institute of governing body, AIMS, Patna. He's a member executive council, UP. Medical University, Saifa, Etawah. He's a brand ambassador for COVID vaccination and national COVID expert. And we have Dr. Yash Zaveri, who is the head of CCM and Emergency Medicine, Region C Health, Lucknow. Is the gold medalist in anesthesiology with 17 years vast experience in critical care medicine. He has been awarded Presidential Citation, Indian Society of Critical Care Medicine, consecutively for 4 years, from 15 to 18, and is a keen researcher in CCM and credited with 30 books, chapters, and more than 40 original articles. What I would suggest that we would also basically invite doctors Alok Aggarwal to be on the dais, Dr. Rajesh Rajput, Sandeep Mishra, Dr. Sandeep Mishra, Dr. Sandeep Mishra actually has come. Can you see if he's outside? Dr. Sandeep Mishra, Dr. Altamash. Altamash, is he joining us on the... Hello? Swati? No? Yeah, so he is joining on Zoom. And basically, after one case presentation, we will briefly discuss about the long haul COVID, that are the late complications of COVID. So, thank you very much, and I leave it to Dr. Yash Javeri.
Thank you.
Please.
Thank you, Mr. Joshi. At the onset, I'd like to thank Dr. K.K. Aggarwal family and Eris Life Sciences to have me here. We all cherish fond memories from Dr. K.K. Aggarwal. We all paid homage to him. My first connection with Sir was during my internship when he came to Chennai for a inter-college quiz competition with Dr. Narottam Puri. And then later on, many years in Delhi, Horse Khas village, we have been interacting. And he has been inspiration during COVID also to start online teaching and education and how to reach to masses. That was the probably USP from Dr. K.K. Aggarwal. Can you please display my presentation? Yeah. Okay. So the title is Bad COVID Cases. Bad COVID cases, hospitalized, managed, recovered. Good times become good memories and bad times become good lessons. So the outcomes might be bad or good, that does not matter. But what you do in the due course of treatment is most important. Your intent and your line of treatment should always be good. No conflict of interest to declare. The learning objectives from this case, we have to be contextual. What we practice in a tertiary care center might not work in a community healthcare center. In your same setting, you should know what are the limitations of your manpower during day or night, and you have to work accordingly. Evidence is dynamic, especially in COVID, so we have to update ourselves. COVID is a great mimicker, not only in presentation, but also in long haul. Infectious disease differentials always remain, especially in Indian perspective. Treat the patients, not the numbers, especially if we talk about the D-dimer, IL-6, and we were always perplexed with all these big numbers. The biggest lesson from COVID for all of us is invest in infection control prevention. An ounce of prevention is better than a pound of cure. Medico-legal issues and documentation. However bad the situation is, whatever best intent you put into patient care, if something goes wrong, patient will have no sympathy for you. So always document what you do. We had this patient on 9th of May. He was in fact admitted through Sonu Sood charity to us. He was a singer in Bollywood. He was admitted with severe breathlessness for 20 days, progressive weakness for 20 days. He was moderately malnourished at time of admission. So we admitted him in the ICU. He was on high oxygen support while he was admitted. What does this high oxygen support means? It has no context. Above 15 liters of oxygen, if we use, we all have understood it goes waste. And the amount of oxygen which goes waste above putting flows above 15 liters is tremendous. So we have to always remember supraphysiological targets, supraphysiological doses of any drug does not work. This is the lesson number 1 from this case. So the patient was directly admitted to COVID ICU. Patient was initially started with steroids, oxygen supplementation, low molecular weight heparin, and other supportive therapies. Patient was given oxygen support with different devices as was clinically required. At times, patient has to eat, so his BiPAP was removed. At times, patient was on high flow nasal oxygen, and his high oxygen requirement was very, very fluctuant. I'll show you in details. One day it was 15 liters, other day it was 4 liters. So always perplexed us. Screening clinical specimens were sent for cultures. His RT-PCR 2 days before his admission was negative at another hospital. All the relevant investigations were sent, so he was treated as presumptive COVID. So again, the lesson here is use what works. If you are not comfortable with a particular device or a particular drug, do not jump to use that drug. Use what you are best trained to use and what's available to you. Especially the debate was between NIV and HFNC those days. The jury was still out. We were also confused. So whenever the oxygen requirement was very, very high, work of breathing was high, CO2 levels were high, we tried to use NIV as against patients whose work of breathing was not excessively high, or if CO2 was normal, then we use HFNC. So it was mix and match all the time. We have to also remember there are best case scenarios which we always read in our textbooks and journals, which generally does not apply to the routine practice, the real world. So we have to look at the real world scenarios as against these best case scenarios. And When the pandemic was peaking, we were probably in the worst case scenario. The patient did not consent for intubation, despite on third day, patient was very tachypneic and he would have been intubated otherwise in the routine circumstances. His oxygen requirement was 15 liters per minute with an NRBM, SpO2 was about 80%. He was on NIV plus ventilator, NIV on ventilator with an FiO2 of 1 and he was prone. Work of breathing reduced a bit, say his respiratory rate come down from 38 to 25 to 28, but again it was transient. HRCT on 10th was scoring 38 out of 40. On 10th, his oxygen requirement decreased to 6 liters, simple face mask, SpO2 93%. 11th, it was again 5 liters. Consent and documentation is must. Why I'm again and again emphasizing on this? We did everything for this patient. The cost was also quite brought down drastically, and the whole team was behind this patient. But after the discharge, the patient gave very, very bad reviews about the hospital. People were not shifting out of the ICUs, but he had 2 or 3 serious life-threatening episodes during admission. That is why he was not shifted, which were very well documented in the records and video recorded also. Use what works. The guidelines have to be contextual. We have to also do oxygen rationing, especially when we are in crisis, when oxygen wasn't short. Triaging. Triaging becomes very, very important, especially in pandemic times or when our resources are overwhelmed. We have to look at the patient, what level of care the patient requires, which patients require admission. At times, there were patients who were very resourceful. They were queuing up for admission. 1 or 2 liters of oxygen, they wanted to be in oxygen because it's a safe place. So we have to be very, very ethical in triaging also. Prime non-monster, whatever you do no harm to the patient, especially in context to newer intervention and newer drugs. Everybody started using drugs which they have never used. Otherwise, these patients should have been referred to the right specialist for using such drugs. Diagnostic workup always have to be thorough, whether pandemic times, whether you are overwhelmed or not. Always have an open-minded approach, streamlined framework for research and development during your work. So this is the oxygen requirement. You can see it is so fluctuant. One day it was high, one day it was low. So we have no trend of oxygen requirement actually. And what was working, we were not sure at all. He had an episode of septic shock on 19th May. Antibiotics were escalated and sepsis workup was done again as a new onset sepsis. 20th of May, we did an HRCT, which showed diffuse ground glass opacity, interstitial septic thickening, crazy pavement, and there was some fibrosis also. His CT severity score at this point was 25 out of 25, and he has mild pneumomediastinum also. Now we were in a fix whether to use NIV. Patient has not consented for intubation, the family. New onset sepsis, always do a fresh workup. However critical the patient is, if the patient has new onset sepsis in the hospital, always do a fresh new workup. Common things are common. Gram-negative infections are much common than rare infections. However, if you have a host which is immunocompromised, as was this patient, you need to do a detailed workup from infection control point of view. Threshold for HRCT. This is what I learned during COVID pandemic. As an intensivist, I had a very, very low threshold for, high threshold for HRCT. And generally we used to work with X-rays most of the time. But during this pandemic, we realized if a patient has pneumonia, our threshold for HRCT should not be very high. This was the hospital course. His stool-occult blood was positive on 21 of May. NORAD was tapered till 24th of May. 24th May onwards, he had diarrhea, 4 loose stools, and his oxygen requirement was 5 liters at this point. He was shifted to isolation cubicle in the COVID ICU on 26th, a day after his diarrhea started, on suspicion of Clostridium. There was some bleeding per rectum, so Eliquis, which was on, was stopped. Diarrhea continued till 26th and 27th. 28th, patient blood management, tranexamic acid and vitamin K, everything was started. What I want to highlight here, patient was on steroids, patient was on antibiotic, patient was moderately cachexic, patient was not eating well. So he had houseful for induction of stress ulcers. This was Clostridium, It was steroids, patient was on antifibrotics. What was contributing to these ulcers and bleeding was still a suspense for us. Diarrhea could persist in some of the COVID patients for a much, much longer duration. It is seen in long COVID also. So that was also in one of the differentials. Anyhow, we have sent Clostridium difficile toxin assay for this patient and started on oral vancomycin. Hospital course colonoscopy was planned and it revealed large irregular shaped multiple ulcers with overlying slough causing a pseudomembrane-like structure. Biopsy was also done. Oral vancomycin was started. Upper GI endoscopy was not consented. His SpO2 fall down to 80% during colonoscopy. So we were also not very keen to push for upper GI endoscopy that he might require intubation. He had an episode of critical GI bleed on 28th May. Lower GI endoscopy, I already told. Bleeding continued and more blood products were required. Overall, he was treated on lines of pseudomembranous colitis at this point. These are the D-dimer levels. You can see most of the time it was well below 200. However, one value was up to 557. We treated this patient with low molecular weight heparin as we would have done for any critically ill patient. After a few days, we shifted the patient to apixaban, and once there was GI bleed and stool occult blood was positive, we stopped it totally. CRP values were 58 to 27.5. We did a homocysteine level also. It was 11. C. difficile toxin assay came positive after 2 days. So treat the patient, not the numbers. Again, this is a very, very important lesson. When you think you are right, even when you are wrong. We actually don't know many a times, especially in ICU. There is too much of clinical data. There is too much of lab data. There are diverse opinions. So work with the clinical diagnosis and work on it. That is very, very important. You have to follow the principle of parsimony. Do not have 10 diagnoses in your mind. You have 2 or 3 differentials, and the top one you work on it. You have to take this KISS approach. Keep it simple. Pragmatic approach and open-minded approach. Try to incorporate your teammates' view. That is what team is all about. I also learned the new definition of ICU. ICU is nothing but a team. So the most important component of definition of ICU is team. And we have to be very, very appreciative of each and every opinion from the team members. So the patient was ultimately discharged on 30th of May with this diagnosis of presumptive bilateral COVID pneumonia because all through his stay and before his RT-PCR was negative. Septic shock, pneumomediastinum, GI bleed, anal fissure, pseudomembranous colitis. Thank you. Thank you, sir.
Thank you. Can I request all the panelists to please come on the dais? Since there is a time shortage, so we'll combine these 2 sessions. And first I will discuss, please Rajiv, come. So first we'll discuss about little bit about the acute care since Dr. Yash has talked about, and then we'll have a small case presentation by Dr. Rajiv, and then we'll discuss about the long haul. And if I think everyone has agreed because we want to finish it by 9 p.m. So you see, like Dr. Yash presented, we have been managing these acute cases, and the basic principle of managing critical care medicine didn't change. It was the no knowledge about how to treat this patient, which kept on changing: steroid, baricitinib, remdesivir, steroid. So this was creating a lot of confusion. This was one aspect, and now after 2 years, we've come to conclusion, probably it is the timing. Very, very important when to give a particular medicine. Because if you delay, then it doesn't help. That's what we realize all through this. And the people now, the survival is more because the timing has really changed. And not allowing a patient who is desaturating at home. Now, at least in this situation, please don't advise your patients and that they should not treat, because everybody has an oximeter at home and they keep on coming late, and then it is difficult. So they should be now, because it's not that pandemic, they should be in hospital if anybody gets COVID. Other thing is that all these hypoxemic patients only should be given steroids. A patient who doesn't require oxygen should not be given steroid. So this is also sorted. Remdesivir can be given in these patients, and if a person is a high risk, if he can afford monoclonal antibodies, which is a cocktail of two drugs which is available, should be given, and we are giving it. So this is all also sorted. Recently, a new drug has come in which has shown a good promise. That's a baricitinib, and they have shown people have given for a long time, and they have also shown promise with this drug. So basically, these drugs which have found some role. As far as the critical care is concerned, oxygen, of course, but this giving 15 liters on a high flow oxygen for a long time has caused a lot of harm. I feel because you give almost 90% of oxygen and it does contribute to some kind of fibrosis. Then the role of non-invasive ventilation and HFNAC. Any can be given, but you should not delay too much of ventilation because your infection control practices should be improved, because if you delay intubation, I have seen these patients don't do well. They don't do well on prone positioning, or I have done people on a very 2 months of ECMO, they don't do well if you do not intubate also at appropriate time. So they should be in a specialized center and they need to be intubated. Do not continue on a 90% oxygen on HFNAC or NIV, because people only survive if you don't ventilate. Please get this idea out of your mind, because we've seen the people who were ventilated when they were not maintaining on these or requiring 90% or 80%, they should be ventilated. And the rest of the treatment, low tidal volume strategy, everything remains same. So I'll ask Dr. Suryakant, before we go to long haul, what is his opinion about managing these patients?
First of all, I want to congratulate Dr. Yash for a very challenging case, especially in a corporate setting. I belong to a government setup, but I feel that in government setup, you have a lot of umbrellas to protect yourself. In corporate setting, when one is paying heavily, if he's paying heavily, he's asking too many questions. So it was a really challenging case for you, because you managed initially, of course, it was a presumptive COVID, and as we know, the management of presumptive COVID is as the COVID, because 30% chances are that yet RT-PCR can be negative. Sensitivity is only 70%. The second thing was the course of the management process. If you just see in the last PPT, which you summarized, Dr. Yash, beautifully, that you see there is always a double-edged sword, Dr. Chabla. Whatever you give, if you give oxygen, you said yes, there is a chances for a lot of fibrosis and a lot of other complications. If you give high pressure NIV, then of course there are 10 to 13% chances of pneumomediastinum and pneumothorax as your patient faced. So, and of course, the coincidentally or unfortunately or by complication or by thing, the bleeding per rectum. It's a serious complication. Bleeding anywhere from any part of the body is a serious complication. And of course, to manage a patient who is bleeding heavily from any source, and of course, a lot of vasopressors you gave, and then of course, the patient could be survived. So I think that yes, Dr. Rajesh Chabla, you are right, that one should remember that the judicious, first is the judicious use of steroid and judicious use of oxygen. The problem is that the whole world is propagating that only two things are working, only two magics are working. One magic is oxygen and second magic is steroid. But problem is that how to use judiciously. Yes, they are doing wonderful job. They have done wonderful job in first wave also and second wave also, but they should be used judiciously. If patient oxygen saturation is above 94, you must not give steroid. That's one message. Because it's a mild COVID, and of course mild COVID, they are still in phase of viremia. So if you are giving at this stage of steroid, you may increase the viral load. The second of judicious use of the steroid, of course, oxygen. Then of course what happens usually in government hospital, of course you are doing rationing of the oxygen, but in government hospital what happens when they are hospitalized, and oxygen ka wo regulator बढ़ा बढ़ा के everybody want that my oxygen should go 99, 99, 100. And that is very problematic. So I think we have to propagate our fraternity and community also that yes, please don't keep oxygen saturation above 92 or 93 or 94. It's harmful. The third thing, as you mentioned, the HFNC versus NIB, again, is a very debatable thing. But yes, if you, of course, if you are happy, if CO2 retention is there, you can use NIB on priority basis. Hypoxemia is there, but for a long-term high flow oxygen, Dr. Chawla, I am very much agree with you that long-term high flow oxygen use is not a good practice. So thank you very much.
You know, the another very important thing, Rajesh, I'm going to ask you. See, I think all of you sitting here struggled with diabetes. People who are not known, they had a very high sugar for a long time, and people who had diabetes, very difficult to control. So what is your advice on this?
Well, although we are already a second world highest capital having number of people with diabetes, but you are right, large number of people are newly diagnosed during COVID infection. And there are many theories for that. We will not go into those details, including direct toxic damage to pancreas, to ACE receptor expression over there. But then problem is aggravated by two things. One, there is a cytokine storm which is happening. Number two, high doses of steroid. And it is not only timing, it is dose also. Although the recommendations are there to use how many doses of steroid. Recovery trial has used only 6 milligram a day. But we have seen people using 8 milligram twice in a day, dexamethasone, which is a very high dose. People are using 250 milligram of methylprednisolone for 5 days or 7 days. So the problem is compounded by our genetic background, predisposition for diabetes, injudiciously very high doses of steroids which are used for a prolonged period of time, and then over and above cytokine milieu. And definitely it has made diabetes a difficult, challenging problem. But what we have done at our institutes, probably in all these patients who are admitted in ICU setups, basal bolus insulin regime is the best regime. We have to utilize basal bolus insulin regime. Unfortunately, in most of the hospital, I am also working in a government institute hospital, most of the other places, people are not very much comfortable with basal bolus insulin regime. They still are utilizing in India sliding scale insulin regime and do not give proper cover with basal insulinization. The result is there are spikes of hypers and hypos. And that is what problems is often coming to us. That morning we have seen sugar of 360, evening the sugar is 80. So these are the challenges. So to overcome these challenges, what we advocate, all the hospitals, whether they are private hospitals, whether they are government hospitals, they should give ready-made charts and instructions to nursing staff and to the critical care staff which is working there. That if patient is coming there with diabetes, uncontrolled sugar, you have to put patient on basal bolus insulin therapy. And then obviously based on the sugar profile, we can titrate the dosage of all the insulins. But then with steroid, definitely it is going to be a challenge. Another very important thing which has come up in COVID is use of metformin. Until and unless patient has uremia, serum creatinine are on the higher side with eGFR less than 30 ml, or patient has hepatic derangement, because that is again a very important issue during COVID times. Otherwise, all patients should be given a metformin, because metformin is the only drug which is going to not only reduce your insulin resistance, going to make insulin work better, which you are giving exogenously. Also, I do not know how many of us know, actually metformin was initially developed as an anti-influenza drug. And later on, actually, its hyperglycemic efficacy was realized and it was developed as a diabetic medication. So metformin also acts through number of other pathways where it is useful. And if we see all the meta-analysis of all the drugs, it is metformin which is found to be the best medication. And again, metformin is highly underutilized during COVID pandemic all over the countries. So we always advocate that start metformin, except only in those situations where patients are not, or it is contraindicated, like I have told you, renal failure or liver failure. So these are few of the important messages that are important. And the biggest challenge, again, I will stop because otherwise we'll, that we have to follow one protocol. Unfortunately, whatever protocol you are comfortable with in your hospital, the staff should follow that protocol seriously and should adhere to it. It should not happen that I am today on the duty, tomorrow Dr. Yash came and he will start something different. So the patient sugars are not
He
going to
will
be
not.
there. So, thank you.
Okay, no, I am going to ask very important, which I felt all through the management of COVID patient to Dr. Sandeep Mishra, who is a cardiologist, that, tachycardia, which we found that most of the patient had a tachycardia and it persisted. And some of the patients, even after 2 months, the tachycardia is persisting. We have not done cardiac MRI. There was a report from All Institute that they noticed endotheliitis, and which is probably the reason. So what's your view on this?
I think it's a very good question, and I would say that actually COVID is a three-phase disease, and people generally think it of as two-phase disease. So I think first phase is viremia, where a lot of infection is there because of virus. So it's a virus infection. Then once the virus infection comes, then there is a start of inflammatory and antibody response by the body. So it's a defense mechanism that gets activated, which includes the inflammatory markers and interleukins and all those things. And that phase is generally focused on either lungs, mostly on lungs, but also on heart and kidneys. And that phase lasts for about, let us say 7 days or about 10 days. And then starts the third phase. And by that time, because lung infection improves, and so people are getting discharged and they go home and they think they are cured of COVID disease. But this is the start of third phase. And that third phase is that some of the inflammatory things come down, but a lot of inflammatory markers are still persisting. And, I don't know whether you have read, there is, activation of mast cells and histamines are released. And I think that low phase of inflammation, which persists for another 3 to 6 months. And that is the reason why there is a vasculitis kind of thing. And that vasculitis kind of thing and myocarditis kind of, thing, but particularly vasculitis kind of thing, which is subclinical, and that leads to this response, tachycardia, etc. And interestingly, that persists for another 3 to 6 months. And because of that vasculitis thing, you hear that person got discharged and week later, 2 weeks later, got heart attack and has come back. This is because there is a persisting inflammation in the vessels, and which makes it more thrombogenic, very easy to get the thrombus formed. And D-dimer is something which you can keep monitoring and can help you there. But it is not only D-dimer, but there are so many other inflammatory markers which are increased. Some of them we don't know at all actually, but they persist for 3 to 6 months. And I think that is the thing. And you have seen that people go to gym and they start gymming after 1 month, thinking that they are cured of COVID, and they suffer sudden cardiac death. So, what I want to bring to your notice is this third phase. I don't call it post-COVID. I call it actually third phase of COVID, which is this persisting inflammatory, response, which may go as long as 6 months. So
in continuation of this, may I now invite Dr. Rajiv Anand, who is very restless. So he's going to present a case of long COVID, and on that we will take all the question related to that. Following that, please, Dr. Rajiv. Inka slide.
If you allow me, I can just add one small bit that, you might say that there is a lot of tachycardia, there is a lot of fatigue, there is lack of sleep, etc. And the treatment is famotidine, very interestingly, because it is a histamine receptor blocker. If it is a very serious case, you have to add cetirizine as well. But famotidine, the top dose is 80 mg TID, but lower dose could be 40 BD, something like that. So
Ivabradine has been used rampantly all over.
Ivabradine does not act on histamine at all. So you have to block the histaminic receptors in this post-COVID situation.
So what should be the minimum dose safely can be given?
For famotidine? 40 mg BD or 40 mg OD even.
Rajiv is a very eminent neurologist. We are friends for a very long time. So he's going to present.
Thank you, Rajesh. I'm not restless per se, but this is an exciting evening and a very important evening where we are together because of one person. Even if we have not known him personally, he was an open lighthouse, I'll say. So it's an open house where our source of light is Dr. K.K. Aggarwal. And I also thank Aris Life Sciences to have brought us together here. It's a unique evening and probably my first evening after 23rd of March where we are gathered like this. Otherwise, it was Zoom only. I'm not going to present a case, but probably whatever has been talked about, can you start my slideshow? Whatever has been talked actually is there in my slides, which I didn't know what was being talked. So it will be a befitting summary of whatever we have talked. Only thing what I have learned is it's my knowledge about anything which makes me aware of my ignorance. So similarly, it's our present day knowledge of COVID tells us that we have yet to gain supremacy over COVID. COVID still is supreme today. Whatever we learned on day one became redundant subsequently. So similarly, whatever we have known till today, our experts are telling us we have to judiciously apply to it. It has been a tremendous, next slide, tough year for whole of the civilization, human being in many ways. And it is definitely, I believe, one of my colleagues was telling that people will forget it. But I don't think it will allow people to forget it. The second wave which came to Delhi and probably to whole of the country at different times and probably to whole of the world is not going to allow us to forget it. It entered homes, it entered everywhere, it entered, you can be most privileged and most underprivileged, and it probably is an equalizer, whatever it is doing. And even the knowledge, what you gain, makes you aware of your lack of knowledge. It is the knowledge, it's not the, so it is making us humble that we know very little about it. And I also agree with Rajesh when he said that we have by and large controlled it, but one surprise can be a variation. So variant, new variant coming up. So that's another issue which confronts us. But in any way, I'm thankful to Aris and KK for having given us an opportunity. Even though I was not a very close associate personally, but I am in the Delhi and we met on many occasions, and you almost need and that endless zeal to learn and disseminate knowledge to actually win over COVID, even today, though it is almost 1.5 years. But any day can be beginning. Today there is, like we were saying, less than 50 cases we are having, but today it is 55. So it sends an alarm bell that there is 20% hike than yesterday. So we have not gotten over COVID as yet. That's one thing I know of. And this is what was one of the questions, how is COVID pandemic? We have dwelled over it, and I feel it has affected everybody. And effect is continuous. That is what long haul is. If not physically, we were talking about tachycardia, I'll comment about that also. If not physically, it's emotionally, financially, socially, in every way it is challenging. In some way, we doctors were fortunate that we never had to stop and jailed. People were virtually living in jails. Right from 23rd March onwards, me and Dr. Chawla work in similar circumstances. So we were on the job. So we never felt that sense of being jailed, but we were also threatened by getting infected. Most of us actually got it. Either your family member got first or other person got first. And so this is what COVID did to all of us. Everybody can have stories. Next slide. So this is, it's not a case presentation, but this is the presentation. So it didn't break the system. It exposed the broken system, which is still broken today. So that's what the job which is left. And that's what the job all of us to take. So one of the legal experts who was here was telling me, doctor, don't bother about other things. But it's high time, like KK took a lead as a leader, doctors should also assert themselves in public policies so that those policies are people friendly. Most of the time, people are not going to listen to you. People are not going to give you what you need for patient to be cared of. Infrastructures are not there. And the whole blame comes on the medical community. That act is passed by. There were draconian orders throughout the pandemic. Draconian orders against the doctor by the magistrates or whatever the powers may be. So we need to work upon that. And that is also going to be helpful to you and your patients. Otherwise, medical science per se may survive, but the practice of medicine will not survive until unless we become stronger to help our patient. Next slide. So I hope the lesson will really be that we can't afford as a society to create the fire brigade once the house is on fire. We need the fire brigade ready all the time, hoping that it never has to be deployed. So this is what is needed. Otherwise, we are not prepared even today. We increase the number of beds, we increase the oxygen, we increase everything. But this is just first aid. It is not the treatment of COVID because we don't know the treatment of COVID. We don't know how to attack this virus and eliminate this virus. We are all saying we are living under the fear that it might come back again. So we know the first aid, and even for that first aid, we do not have the resources when it overwhelms us. No country can have it, but we were particularly unfortunate to be blamed for it also, whereas it is not our fault. Next slide. So this is what long COVID is. Even if the virus is out of your body, this is how people are. Next slide. So somebody was alluding to first wave, first, second, and third part of the COVID. So COVID definitely has an acute phase. Then there is a persistent of some symptoms for longer period of time, up to 4 weeks in the same patient, which may be continuous inflammatory phenomena. And then there are symptoms which are beyond 12 weeks, which is called long COVID. There may be different explanation. However, you all know, you all have experienced what we learned in the first wave about the patients, how to treat them was not applicable in the second phase. In the first phase, you had days, patient will have symptoms, then you knew that 7 days, 10 days, if it is over, patient was safe. But the second wave, my critical care people will know, and they know it better, that we could not predict when it is safe. Just now we have said that the patient may have sudden cardiac arrest. We have had patient. So I always used to say, Dr. KK Aggarwal, Dr. Shekhar Aggarwal, they knew what is the best treatment. They got the best treatment, but the COVID won. So therefore I say that whatever principles we have learned are not complete. They are still incomplete. In fact, I feel that there is a continuous immunoinflammatory coagulopathy which affects whole of the vascular system, be it brain, be it kidney. In front of your own eyes, patient having received the steroids at the right time, patient having received remdesivir at the right time, patient having received tocilizumab at the right time, patient is in the best of the institute in this country. What went wrong? Because we don't know completely what to do at that stage. These people, almost all of you, I as a neurologist know my stroke patient, despite full dose of anticoagulation, and are having a ischemic infarct and a hemorrhage simultaneously. What to do? So we don't know. There are many more things to learn. In fact, today, after acute COVID has subsided, we are seeing patients which are challenging us. So there are more things to be learned today. It has to be continuous process. It's a teacher's day tomorrow. All of the best teacher in us will come out when we continue to remain students. Even in this evening, when I've heard to my colleagues, I have picked up few points, how to carry myself as an individual in the society and how to learn medicine. And then in the end, I was scared that how to practice it safely tomorrow. So these are the challenges which are going to haunt us. I'm not going to talk a lot of theory about how to do it because it's going to take probably many days of symposia to discuss just one topic. So I summarize, it's a immunoinflammatory coagulopathy where you try to treat immunity part with steroids. You're treating coagulopathy part with anticoagulants, but still your patient worsens. So we do not know what is the causation. You must have had, I could have shown you pictures. My one stroke person is doing endovascular embolectomy. People have done PTCA and the simultaneously during their procedure, the clot is reforming. In the same artery, the clot is reforming. So we still do not know the total mechanism. In some patient it works. Ultimately, there are some patient-specific mechanism. Maybe we'll know them better. So next slide. So what we were talking about and what we are going to be confronting is, since the millions of people have got COVID, so now most of us are going to see patients who have got lingering symptoms. In fact, initially, we call them psychological symptom. One of the doctor whom I know works in a government organization. Post-COVID, she was not feeling well. And her boss was issuing her letter that, why don't you join? She used to say that I don't have energy. I feel breathless. I feel fatigue. So these are now we know is a reality. So we are going to confront lot of patients. In fact, in some countries, and Rajesh may be a pointer, we may have to have COVID clinics, post-COVID clinics, where we give them multidisciplinary help to manage their life after post-COVID. Some of them are physical symptoms, but more than physical, there may be emotional and other issues. Next slide. So these are from So it's an umbrella term. So that umbrella term may mean post long haul COVID, which has now been defined, but I still feel nothing is well defined about COVID as yet. Next slide. So this is sometimes many patients come to me. So I feel I have a dementia. In fact, what is happening is forgetfulness. So people who already had mild dementia became agitated, became more worse, and people who never had, even young doctors are coming and telling me that it is happening like that. Next slide. So next slide. So what I want to stress is a lot of people are having psychological problems. First, next. So next. So I've been told next. So next. So this is what the summary, in fact, what I have been listening to many podcasts, we have seen each and every system being affected during acute phase of COVID, which is known as para-infectious syndrome. Like you have nerves involvement, you have spinal cord involvement, you have brain involvement, and post-infection also. Post-COVID we are seeing, since the time doesn't allow, but we should be cautious that these things are happening to our patients of COVID. Our war with COVID is not over. We have now a lot of people say veterans coming out. So those who have recovered COVID are veterans, but they are also still ravaged. Next slide. So this is what we wish, that everybody should be happy, everybody should be safe, and everybody should be enjoying a good health. Next slide. So prepare for the worst and hope the best. Be safe. Next slide. So this is the article which I just want to give a reference to. This is free article. It gives you everything about neurology in COVID. So you can download it. You can hear a podcast. Next. So this is my last slide. So we must thank COVID for having taught us, because this is tomorrow we are going to say, so this is for tomorrow morning. So teachers of the year award goes to COVID-19, taught us what life is about: simplicity, spirituality, and plus uncertainty. Thank you very much. Thank you.
Thank you, Rajiv. Can I request all the panelists to come on the dais, please? Dr. Sandeep, Dr. Suryakant, Dr. Rajesh is already there. So before I ask you, we have Dr. Altamash Sheikh, who is on Zoom. He's a diabetologist working in Mumbai. So is he there? Can I ask him? It's okay, he's not available. So, lot of problems. I think the people, I will ask each one of them because the problems which patients are coming and all of you also must be facing. Any one of you wants to ask any questions and want to discuss or give his comment is most welcome. So let me start from Rajiv only. A lot of patients are complaining that they are feeling weak. And this is a very, very common complaint. I have my friend sitting, Dr. Umesh Mittal. So he will also say that a lot of people. So what is the reason and what should be done?
We do not have guidelines to investigate long haul COVID, but definitely, as I told you, passing reference, one of my doctor junior was having these symptoms. So these are genuine symptoms. Don't pass them as psycho. So this is what we learned. We were, as a clinician, not if I'm not a psychiatrist, we were focused on hardcore symptoms. So these are true symptoms. Try to help your patient. And what to do is what I read and what I heard all over, and what I do with my patient, ask them to improve their lifestyle and start with light yoga, breathing exercise so that their energy level comes back, but it is a genuine symptom. And without your asking, I want to tell about tachycardia also. It's a neurological symptom post-COVID because of definite autonomic neuropathy involvement, and port syndrome also becomes more common. So there are symptoms, and those are genuine symptoms, and those should be taken care of. What I do is, as one of my colleagues suggested, so I do the inflammatory marker again if the symptoms are very persistent. We do not have any data, but the best expert in the field says that sometimes if there is a persistent inflammation, a very low dosage of steroids may work, but you have to be very specific. You have to see that you are not harming the patient. So these patients have to be re-investigated. And another thing which our colleague in critical care medicine told, that in ICU you recheck whether you are missing anything. So your patient may be having some other new problem also coming up that also needs to be investigated. So patient should be taken seriously. Full history, clinical examination, and then relevant investigation will solve the issue.
Dr.
Right.
Rajesh.
Just to add, weakness after post-COVID, from endocrinologist perspective, three very important things to be kept in mind. Patients, as I've told you, are given very high doses of steroid and for a very prolonged period of time. So you might have actually induced hypothalamo-pituitary adrenal axis suppression. Now, when you withdraw all of a sudden these high doses of steroid, patients actually started feeling weak for some days. So we have to understand, but we have actually done harm to the patient instead of. So there, for some time, low dose of steroid might help. Second, post-COVID, it's a viral illness. There are reports, and we have published our own consensus statement from Indian Thyroid Society, that there are cases of viral thyroiditis. And with viral thyroiditis, there is an unrecognized thyrotoxic phase, during which patient will lose weight, patient will feel weak. All these things are going to happen. And most of the time, this phase goes unrecognized. And this is associated with increase in ESR, increase in CRP. So unfortunately, if we are relying only on inflammatory marker and measuring CRP, CRP will be found to be high, and we will be wrongly labeling that COVID has again come back. Third very important thing, there is, and we have started this study, new onset diabetes after COVID. Like there is a term, NODAT, new onset diabetes after transplantation. Now we have new onset diabetes after COVID. So these are the three very important things from endocrinologist perspective whenever patients are coming to you with unexplained weakness, for which we actually look into it. And if obviously we are not finding it, then there are many other causes as we have discussed. But then there are a number of causes. So this is from my.
Just one, if you allow me. So I have seen that incidence of Guillain-Barré syndrome also coming up with weakness.
Yeah,
so
that's a very
as he says, and we all stress that you be very patient, listen to your patient and get him investigated.
Dr. Alok, what are the ENT problems the people are coming post-COVID to you, and how to manage them also?
Yes. So, first of all, the people are coming with loss of smell, which was supposed to be the first sign and symptoms. But after the COVID, loss of smell or altered sense of smell. They are feeling that something which is putrid is coming out from the nose. They don't feel taste. They don't feel like eating. So we have noticed in very many patients that there is some degeneration of the sustentacular cells of the nasal mucosa, which is causing the harm to the olfactory system. And in these patients, local intranasal corticosteroids or sometimes a mild dose of the systemic corticosteroids works, or if anything doesn't work, then we emphasize on retraining of the smelling system, like smelling the eucalyptus oil or rosy smell or coffee or something like that, at least 4 times a day, right? And the second thing, which is as far as the ENT point of view is concerned, as Dr. have already explained, that thyroiditis, we have also seen the patients during the COVID time also, that the patients were complaining of pain in the neck. And we got this test done of the thyroid hormone test and anti-thyroid antibodies, and they found that these patients were having the thyroiditis. And we have given them again the anti-inflammatory treatment in the form of some anti-inflammatory therapy, and it worked very well. Third thing which has come as a long haul as the COVID, as you people already know, is black fungus or mucormycosis. It has come very evidently. I don't know why in India, and we have lost so many of patients because of this mucormycosis, and we still don't know why the people were affected so much in our country, not in other countries, as this COVID affected other countries and people in other countries also. But in our country, particularly in Delhi also, a lot of patients of mucormycosis, and this is a dreaded disease. It starts from the rhino, orbital, and cerebral mucormycosis. And the first symptom is the numbness over the face or loss of smell, headache, and then gradually loosening of the teeth. Then it gradually goes to the vision loss, and sometimes into the brain, and it causes death. So many of young patients we have lost, and early diagnosis, debridement of the patient, early debridement of the patient, followed by the antifungal therapy in the form of the injectable amphotericin B, posaconazole, isavuconazole is help, and still till date we are getting new patients of mucormycosis as far as the ENT is
Yeah,
concerned.
I think I agree with you. Dr. Sandeep, you wanted to say something.
I just wanted to have your opinion. Do you see any hearing loss as well? Because many patients have complained that after COVID, the acuity of hearing has been decreased. Or
So it is not related directly to the ear blockage. What happened actually, the patient during the COVID time, as of any other viral infections, have the sudden sensory neural hearing loss. But because the doctor was not available, hospitals was not open, and then this condition goes unrecognized, and patient was not diagnosed in the time, and so active treatment in the form of the steroids, in the form of the antiviral drugs, in the form of the hyperbaric oxygen therapy could not be given, and the hearing ultimately goes on toss.
Yeah, I have a question for Dr. Suryakant. A lot of patients had a lot of fibrosis. One thing you should remember, this is a regressive disease. Like people who were discharged on oxygen, slowly they came off oxygen because the normal lung remodeled, and they were off oxygen, first at rest, and then slowly over a period of few months, they were off oxygen. What is the question to you is, what is the role of this Perfinex and 9-antidenib? Although there is literature is very silent and not proven. So what is your opinion and what is the advice?
First of all, Dr. Rajesh Chabla, there is no clear-cut guidelines either in our country or internationally for the use of pirfenidone or nintedanib. We have also published a consensus statement in the Indian Journal of Chest Disease and Allied Sciences. If you go, that is the post-pulmonary, post-COVID pulmonary sequelae. And in that also we have said that there is a individual case reports or some individual observations which have come up. But this is my personal recommendation that you should not be in hurry in using pirfenidone and nintedanib. Basically, post-COVID pulmonary fibrosis is not idiopathic pulmonary fibrosis. People get confused that, and they are started treated like a idiopathic pulmonary fibrosis. It's not a idiopathic pulmonary fibrosis. And with the lapse of time, there is a lot of improvement, as you rightly mentioned. So have a wait and watch. In certain subset of patients, you can use pirfenidone or nintedanib depending upon the situation, but don't be in hurry.
The next question is to Dr. Yash Javeri. A lot of patients have come with opportunistic infections. See, like one Dr. Alok mentioned about the mucormycosis. A lot of patients came with CMV infection, the galactomannan being positive, and the new terminology has come, COVID-associated aspergillus disease. So what is your experience on the CMV and the fungal infections and the other PCP and other infections?
Thank you, sir. The risk of hospital-acquired infection, especially in immunocompromised host, depends on many factors. One is duration of hospitalization. Second is degree of immune suppression. And third is exposure from the healthcare facilities. And probably we had household during COVID. Steroids were used indiscriminately for a longer while, which caused immunosuppression. There are many theories where COVID-induced immunosuppression, we are talking about as we talked about post-viral immunosuppression. Many drugs, antifibrotics also cause some degree of immunosuppression, lymphopenia, various lineages of TLC were low. Those were also adding on to risk of immunosuppression. Added on, our infection control practices during the first wave were excellent, but second wave, most of the centers, they were not at par. So the risk was much more. And especially if we talk about pulmonary infections, we always kept a differential of CMV, PCP, TB also, because everything was being labeled as COVID and we had everything there. So instead of labeling everything as COVID, especially in patients who have coming late or patients who have been transferred from some other setups, we have to be vigilant on diagnosis of infections such as COVID-associated pulmonary aspergillosis, secondary bacterial pneumonias, CMV. We had a patient of CMV pneumonia also during the course. So it was not common, but again, it was not rare also.
Yeah, because when patient is admitted in the critical care and is in the hospital for almost 1.5 months, and if he is not responding, all these should be tested, because we've seen all these cases and many of them on the specific treatment they responded, and these 4-5 kind of opportunistic infections are very common. So before I wind up, anybody wants to say anything? Anybody from the audience wants to? Yes, sir. Can somebody give him the mic? Because the Dr. K.K. Aggarwal wanted to teach, so anybody wants to teach is most welcome. Yeah.
I think I'm the most unique case because I had 3 times I had COVID. Once I had asymptomatic, and my case is presented in Frontiers of Medicine. In August, I had asymptomatic. I was going to travel last year, August. I was going to travel, so I got my RT-PCR done. It was positive. I didn't have any symptoms. Then I got my vaccination, beginning of Feb, and then 15th of March. And then 10th of April, I had severe abdominal pain and high fever. So next day I got my CRP done and it was 100. And then I tested positive for on RT-PCR, and my CT value on the RT-PCR was 34.5. And the stomach pain continued. I started all the medications. Dr. KK thought it was probably a thromboembolic complication of the vaccine. And so he started me on blood thinners and steroids. I took the steroids for 10 days. I had severe weakness, but suddenly on the 22nd, I was like magically okay, and my CRP had come down. So I started feeling all right. Dr. KK started fever on 26th, and he tested positive on 27th of April. And we admitted him to the hospital on the 1st. First and second, I was with him in the hospital. Third, I had high fever, so I didn't go to see him. And my RT-PCR was positive. My CT value was 18. My between the two episodes, 2 of my RT-PCRs were negative. My chest CT was clear. When I repeated the chest CT, it was 3 on 25 pneumonia. And on the 10th, my CRP was 250 on the 10th of May, when Dr. KK was already admitted. So I was rushed to the hospital, and I was there in the ward. All my inflammatory markers were very high. My CT chest showed 14 on 25. So I was there for 5 days, got the entire treatment and all. I got my genome studies done. So I had my samples from the previous April episode. Then I had my other sample from the May episode, and I did KK sample also. And so the first April episode was a UK strain, and the May strain, both KKs and me, was Delta variant. So
So you are scaring us, because if you had with one strain and you got another strain, there could be problem. I think there are a lot of things still we don't know about this disease, and the recurrence is very, very rare. Even if you have infection with one strain, it does protect you from the other strain. Not completely, but does.
It was an immune escape, as is well known with Delta. So it is, my case report is published in Frontiers of Medicine. And I think I'm the only person who's a documented reinfection, breakthrough infections. Because nobody has access, they don't have it so quickly within a span of 5 days. I guess because I had things, I could document it. And what I wanted to know
You
was,
were symptomatic at all 3 times, right?
first time I wasn't symptomatic, but second UK strain and the Delta strain, I was symptomatic. Delta strain, I was in a very
So
bad
can I
shape.
comment?
Yes.
Rajesh, can I?
Yes, please.
So what is being touted is there is persistent viremia. You never clear. If the same strain occurred again, so you are not clearing it forever. So the moment it is a play between, so there is a theory going on that some people may be having persistent non-manifest, like we have in herpes zoster. So the virus persists, and whenever patient gets single. So similarly, even tuberculosis is a reactivation of existing tuberculosis. So as he says, we don't know the final answer, but that is one of the theories.
The genome studies and the clades, how typically they have a microbiologist say that there is a difference in clades, and there were 2 negatives in between. So it was all proven that it is a new strain. It was a Delta strain. It was a immune escape. So that's a short proven case. That's why it's got published also. My question was, I do have brain fog by the evening, but I pushed myself because I had no choice. I had a lot of work, thrown at me. So I pushed myself physically and mentally. So I don't have, thankfully enough, I don't have too much of long COVID symptoms right now, except for a little brain fog. Is there something I should be careful about? Is there, it's what, 3 months now?
I mean, there is nothing which can, the same precaution which everyone takes, you need to take that. That's the only thing. And I'm sure you must have been vaccinated as well.
I am twice, both my doses with Covishield. I was more than 40,000 post. They
So
couldn't measure it.
because you have a T cell immunity and this B cell immunity. What's your question? Anything very burning? Okay.
So thanks to Dr. Kiki Aggarwal and thanks to Avis for wonderful unilateral teaching program today, because we were not able to ask, but we learn a lot. My only comment is, this is a simple viral fever with unpredicted morbidity and mortality. When initially we had episodes of viral fever in our day-to-day practice, initially we are scared of the things and we take complications. Same is true with the COVID first, second, third. So I just want to know from learned speakers, is there any clue to prediction of course of COVID in particular patients? What are the factors which will affect, like madam suffered and did not harm, husband suffered and succumbed to death? So what may be the predictable factors if we know?
It is still not known, but I think the genetics also and your immunity has some role. That's what, so far it has not been really sorted out, although a lot of risk factors people have come out, predictors of mortality, but really to pinpoint like you are asking, it is still not. Anybody wants to say anything?
You are correct. Actually, so many risk factors has been laid down in various studies, right from obesity, presence of diabetes, presence of cardiovascular disease, so and so on, we can name. But still there are people like she has narrated her case, or even thin and lean people like Dr. KK, they have suffered badly. So still our knowledge is incomplete, and I personally believe it is principally the genetic constitution of the individual and the immunity, which is actually ultimately making the difference.
So I think with this, we are celebrating today a teacher and in his memory who used to teach, and this can go on, and because we have a limitation of time. So COVID, still we've not understood. Lot more to understand, lot more to learn from each other. And I think almost 50,000 papers have been published on COVID, and still simple answer question which she's asked, we are not able to answer. And I think we need to continue our strive for learning so that we can help more. And with this, I thank all the panelists, all of you for your patient listening. Thank you very much. And hand over back to you.
Thank you, doctors, for making these deliberations very insightful, very thought-provoking, and also inconclusive. Nobody knows what exactly is going to happen. So this was quite interesting. So I think, we have to basically keep our guards up, follow the COVID appropriate behavior, and do all proper things, to protect ourselves from COVID. May I now invite Dr. Veena Aggarwal to be on the dais, and this is the time to felicitate all the panelists, all the faculties for their active participation. May I invite Dr. Mukesh Mehra to be on the dais? Dr. Alok Aggarwal. Thank you, Doctor. Dr. Rajesh Chawla. Dr. Rajesh Rajput. Dr. Pankaj Vats. Dr. Pankaj Vats. Dr. Yash Javeri. Dr. Suryakant. Dr. Sandeep Mishra. Dr. Rajiv Anand.
The Joker is back.
Thank you. Thank you. I now invite Deepak Kapoor to please come and give your vote of thanks. Thank you.
Thank you, Mr. Joshi. So, doctors, good evening to all of you. On behalf of Ares Life Sciences, we are extremely thankful to Dr. K.K. Aggarwal's family, who has given us the opportunity to host this program in the memory of Dr. K.K. Aggarwal. We are really thankful to all the speakers, panelists, and the august audience, those who have joined us here as well as at various places across the country, and those who have joined us over this Zoom through the webcast. Although we have talked enough today for Dr. K.K. Aggarwal, but I still feel that we have not talked anything, whatever personality he had. We all know that Dr. K.K. Aggarwal was very much involved into the academics, whether it is a teaching, whether it is guiding, whether it is the work other than the medical fraternity. But one thing probably I would like to tell each one of you is that probably he is one amongst the very few doctors, those who were in everybody's house. I still remember when Nilesh came to Ahmedabad and we were discussing about this program. So I went back at Mumbai, and out of enthusiasm, I spoke with my wife about this program. And she said that Dr. K.K. Aggarwal तो हमारे को बड़ी अच्छी तरह मालूम है. I was a little surprised because in last 25 years, we have never talked about the profession in which I am there. And she has not taken anybody's name other than our family physician. So I was very surprised. I asked her that how come? She said that I have seen so many videos and it's so much of inspiring video. And we have learned so many things which as a household lady, we have never thought of. That is what was the charisma of Dr. K.K. Aggarwal. And I'm sure that he will always remain in our memories. We will try to connect the way he used to connect through the various programs. And I think that whatever has been taken up by him would continue by the other medical practitioners, the August fraternity. And overall in India, the health culture would definitely be much better than what we are seeing today. So with this, once again, a special thanks to the family and all of you, those who have joined us, especially the speakers and the panel members. One thing which I was told is that Dr. K.K. Aggarwal was very much involved into the physical endurance, nutritional endurance, as well as the mental endurance. So continue the trend. We all thought that we should spend good time tomorrow morning at around 7 o'clock onwards to talk more about the mental, physical, as well as nutritional endurance. We have the speakers, those who are coming from across the countries, they are very well established in this field. And I'm sure that that would be a lovely session tomorrow. And to end this, I think one more fond memory which we were told is that Dr. K.K. Aggarwal was very fond of the retro music. And as and when he used to get the time, he used to listen to the retro music. So to give him the tribute, we have arranged the retro band today, which I'm sure that you all will enjoy. With this, thank you very much to each one of you. And then let's join for the cocktail and dinner. Thank you so much.